Naveen, sir. Naveen? Naveen has joined.
Good morning.
Yeah.
Good morning, everyone.
Huh?
Good morning, sir.
Good morning. Good morning.
Good morning, sir.
Morning, sir.
Naveen, sir, good morning.
Good morning, sir. Good morning.
Good morning, sir.
Very nice.
Balabhaskar, sir, good morning. Balabhaskar.
Good morning.
Venkatagiri, sir. Venkatagiri, sir. Venkatagiri is joined.
Yeah. He has joined. He is silent. He will. Hello, Kumar is joined.
Good morning, Balabhaskar sir, Naveen sir, everybody.
Good morning. Thank you very much.
I think we need to have the other judge to be ready, available. He's just about to join, I think.
Namaskar, sir. Good morning, sir.
But yeah, I'll try to call him.
Good morning. Scoring sheet வச்சிருக்காருன்னு கேட்கணும்.
Balabhaskar, sir.
Yeah, good morning.
Good morning, sir.
Good morning. Good morning.
Balabhaskar sir, you have the scoring sheet with you?
I kept it open.
Okay, sir. Okay, sir. Thank you. Thank you. Sir is very always. I'm just.
Girish sir is available. Venkatagiri, sir. Venkatagiri, sir, has joined. No?
Venkatagiri is not, I think he has to unmute. Venkatagiri is not able to talk.
Listen, unmute him.
Dr.
I have joined.
Okay. Welcome, sir. Venkatagiri, sir.
Okay.
Venkatagiri, sir, good morning.
Good morning.
Rakshita, can you stop sharing the poster?
Okay, sir, fine.
See the grid view of everyone.
Okay.
Stop sharing that. Everyone knows we are in PG Conclave.
Now, sir?
Yeah, stop sharing your poster.
Now, is it fine, sir?
The gallery view, we will want to see. Yes, okay, good.
Yes.
Thank you. Just about to join. Once he joins, I think we should be able to start.
Who has to join?
Sorry? Rakshita, you can allow everyone inside.
Yeah, sir. I'll admit all, sir.
Yeah, admit all, please. 10 o'clock.
Okay.
We have just about 1 minute around, and we should be able to start.
Dr. Naveen, good morning.
Divide sir வந்துட்டார்ல sir.
Yeah, I'm just waiting for him. I called him.
Okay.
He said he's joining, logging in now.
Okay.
We should be able to crack on. Another Ratna Kumar, good morning.
Good morning, Ratna Kumar.
Kiruba,
Yeah,
good morning.
Good morning, Sela. பல இருக்கிறீங்க காலங்கத்துல.
நீங்க தான் கோட்லாம் போட்டு அப்படியே ஷூட்டிங் போற மாதிரி வந்திருக்கீங்க.
இதெல்லாம் உங்ககிட்ட இருந்து கத்துக்கிட்டது தானே.
மாத்தி.
JP sir, good morning.
Good morning, Kumar.
Dr. Kannan sir, welcome Dr. Kannan, Dr. Amudha Rani, Dr. Selvakumar. He did a wonderful job yesterday. 2 days. All A complete Dr. Selvakumar and team. Dr. Ganesan for all B and Ganesan and team. All of the entire team, Tanjore and Trichy team. Great work for the past 2 days. Just look for Dr. Devitia as soon as he finds, we will start.
Can we call him?
I called him. Anyway, you slowly get started, Kripa. I think so. President has to go for a function. You get started with our program.
Right. Shall I?
Yeah, please brief this thing and I will start. Yeah, go on. Clock 10:02. You can start.
Can you mute everyone? Hello.
Yeah.
Good morning.
Rakshita, mute everyone. So, Dr.
Yes, sir.
Kripa.
Yes, sir.
Thank you. Kripa,
Yeah.
Muted.
Shall I start?
yes.
Yeah, okay. Good morning, all of you. We are happy to welcome all of you for our Tamil Nadu ISA PG Conclave 2020 third day program. And it is a very auspicious and memorable day for all of us here, because we have been working very hard for the past 10 days to make this event very successful to every one of you. And for the last 2 days, we conducted day 1, day 2 program. It went on very well and fantastic. So before starting this program, I want to make few announcements. For all the delegates, please note down this number. This is Tamil Nadu ISA WhatsApp number for credit hours certificate. If you need credit hours certificate for this program from Tamil Nadu Medical University, you have to send your name by WhatsApp only to this number. Don't call this number. And chat box rules. Do not type your name, mobile number, or any other details to the chat box. It will be unnecessary disturbance to the participants, delegates, presenter, as well as for the judges. Chat box should be used only to type your questions. Please cooperate with us. And we want to profusely thank our advisory committee, Dr. Ganesh Prabhu sir and Dr. Balavenkat Subramanian sir, for helping this event successful. And we want to thank our scientific committee, led by Dr. Edward Johnson and Dr. Kumar, and Dr. Kumar from Madurai, Dr. Ganeshan from Coimbatore, and Dr. R. Ganeshan from Trichy. And we want to thank all our sub-coordinators, Dr. Sivaprasad, Dr. Sendil Kumar, Dr. Radhika, Dr. Ramya for Hall A, and Dr. Amar Nandakumar, Dr. Manikandan, Dr. Arun Kumar, Dr. Balaji, and Dr. Malini for Hall B, and Dr. Balasubramanian, Dr. Akila, Dr. Sendil Kumar, Dr. Yoga Satya, and Dr. Gunalan for being sub-coordinators for this program and making this event very successful. Thank you very much from Tamil Nadu ISA. And finally, we want to thank all our judges for their kind cooperation. Thank you so much for making this event very successful to all the judges. Thank you from Tamil Nadu ISA. And with that note, we will go back to our program. Now I call Dr. Sudarshan, President of the Tamil Nadu ISA, to call the meeting to order.
ISA Tamil Nadu Postgraduate Conclave 2020 meeting call to order.
Thank you, Dr. Sudarshan. Now we will go on to lighting of Kuthu Vilakku.
Rakshita.
Thank you. Now I invite our President, Dr. Sudarshan, to give a welcome address. Dr. Sudarshan, please.
Respected President, ISA National, Dr. Muralidhar Joshi, respected Secretary, Honorary Secretary of ISA National, Dr. Venkatagiri, respected ISA Academic Chairman National, Dr. Balabhaskar, who is also a judge for the event today, respected Dr. Venkatagiri, President-elect, ISA National in the coming year, respected Dr. Divitia, the immediate past editor of IJA, who is also a judge for the day, and senior past presidents from ISA National, Dr. Chakra Rao, and other senior ISA members, respected Dr. Ganesh Prabhu, who is our governing council member, who is also our guiding light for all our events, and Dr. Balavenkat as well, and all the senior ISA office bearers, president secretaries of various branches, and the delegates, and most importantly, the stars of the day, the postgraduates. The postgraduates have been sort of immensely involved with all the COVID duties and all the responsibilities added to that during their past 7 or 8 months. And they had very limited opportunity, although we had asked them to participate in many of the CME programs and webinars, but their opportunity to present something by their own to fulfill the requirement for the university guidelines to secure credit points has not been fulfilled. The reason to initiate this program was primarily, that's the primary reason why we initiated this program. And we decided that whatever it is, and we should be able to get their credit points. That's where the crunch. We were lucky enough to get the link to the university, the Medical MGR Medical University, which had just released the Gazette note stating that they would approve the credit points given for even online events. So immediately we cashed on that, and then we took up, and then we started this, initiated this program. And with all the coordinated work by the entire team of ISA Tamil Nadu, we are here today. And I thank all the participants who have come today. Have a good day and enjoy your day. And the postgraduate conclave is going to be very, very useful for you. At the end of the session, we are going to have a career guidance, and enjoy the entire day. It will be useful to you. Thank you so much for joining over. Over back to Kripa. Thank you.
Thank you, Dr. Sudarshan. Now I invite our respected President of National ISA, Dr. Muralidhar sir, to give a felicitation address. Dr. Muralidhar sir, please.
Good morning, President Dr. Sudarshan of Tamil Nadu ISA and Secretary Dr. Kirba. It's nice to see like you have over 800 delegates for this PG conclave, and it's phenomenal. I would like to say I've been doing so many programs, like we just headquarters is watching all this in almost a week on week. You're doing every week one CME from each different branches and keeping everybody busy. But it's nice. It's nice. Even though we had the pandemic, we had our own difficulties, but the way we have bounced back in the scientific program and all has been phenomenal. And in fact, still one more task is left for Tamil Nadu ISA to complete. Not that it's their fault. It's a situation like that. We had to register our ISA national office at Chennai, where a half job has been done because of pandemic. We got stuck. Other probably by March 31st, 2020, we should have been through with that one. But well, life is like that. You plan so many things, but it takes its own time to happen. Hopefully, the coming 2021, we should be able to get going, and so that things will be much better next year. And the biggest challenge, what I keep seeing these days, is the amount of virtual events that are happening. Whether we talk about CME, or we talk of the PG assembly or conclave, what you are doing, or probably the conference, the state conference and all, because it's lined up till March 31st. The 2020 conference is lined up till March 31st. And the attendance has been phenomenal, but now it's a big challenge when probably the COVID pandemic. Yesterday I was reading in the news headlines and also experts have felt that India may not see a large second wave, which is a good sign. We're happy about that one. We may not see large second wave, but there could be small peaks here and there, but we may not see large second. That means the life will be much better in 2021 than what is 2022, what is 2020. And definitely the way things are moving and all those things, I think except one or two states, most of the states, things are settled down, people are moving around. We lost a lot of people, probably warriors in the whole process from our own specialty and other specialties also. But that's a price we have paid for the pandemic. And this is one of the best time to live on this planet. I would like to say no major world war is happening. And of course, what a pandemic was there. Yes, we had a lot of life losses, but compared to the previous pandemics and all, definitely life loss has been much less, though every life is very precious. But let's not forget, look at the rate at which the vaccine has come out. Probably somewhere one of the first companies to start was, I think, for some German companies, I think BioNTech, I think, probably you can correct me. They were the first to start the vaccine preparation around, I think, Jan 24th. And I think they said, in fact, they were more for pharma, not a big thing, but suddenly they thought of vaccination because they thought a pandemic might be happening and all. And maybe less than a year, the vaccine is on. Probably it's must be one of the shortest duration anybody has taken for preparing vaccine. But we have to see the side effects and all. That's a challenge for us also. Let's not forget. The challenge for us because vaccine-related problems also could be there. Some probably the anaphylaxis I talk of, or maybe some any kind of side effect because of the virus getting activated, depending on the kind of vaccine we might be using, whether live attenuated virus or probably the protein or the DNA sequence. It depends a lot. The biggest thing what probably in 2021 is we're looking for the kickstarting the Platinum Jubilee celebration of ISA, which was formed in 1947. For this, probably we'll require all your cooperation. But again, I'll repeat. The most important thing is we are going to national registry next year. All of you again enter your data, and it's your data, your privacy will be maintained. You'll be the custodian of your data, and you don't have to pay anything to private party. ISA will be giving all the support to the members. And probably we need some information like how many spinals you have given or how many trauma, because when you go sit across the table with Government of India officials, then you have to discuss with them about the specialty, importance and all. We need this information so that we can say, like, look, so much of anesthetic work we are doing, or so many trauma cases we are handling, or so many head injuries we are handling. So all these things we have to know. So I wish your event all the best, great success, and really happy to see you here. And my special thanks to our Chairman Academic Committee, Dr. Balabhaskar, taking active interest in all the activities, and our President-elect, Dr. Venkat Giri, Honorary Secretary, Dr. Navin Malhotra, our Treasurer, Dr. Surendra Sharma, our GC members from Tamil Nadu, especially Dr. Ganesh Prabhu and Dr. Balankat Subramaniam, and all the past President Secretaries of Tamil Nadu ISA, all the members and all. Definitely, because even the pandemic made us to think twice about how to go about it. Probably we recovered with just a couple of months, we get going. Probably April, May was probably the period when we had a tough time. But subsequently, we bounced like anything. We're having more academic activities compared to last time, probably last 1 or 2 years. So let's continue to maintain the same trend, and we wish the event all the best, success. Long live ISA. Jai Hind. Thank you.
Thank you, sir. Thank you. Now I invited our Secretary, ISA National, Dr. Navin Malhotra, sir, to give the felicitation address. Dr. Navin, sir, please.
President Tamil Nadu, Dr. Sudarshan Kasturi, Secretary, Dr. Kirpakaran, Treasurer, Dr. Ratan Kumar, President-elect, Dr. S. Kumar, Chairman Academic Committee, Dr. Edward Johnson, the GC members from Tamil Nadu, Dr. Bala Venkat and Dr. Ganesh Prabhu, respected President ISA National, Dr. Muralidhar Joshi, Dr. Venkat Giri, President-elect, Dr. Bala Bhaskar, Chairman ISA Academic Committee, Dr. Divyatia, past Editor-in-Chief. It's really very nice, and heartiest congratulations to Tamil Nadu ISA branch for organizing this postgraduate conclave. The postgraduates are the future anesthesiologists who are going to administer anesthesia to all of us. So it's our duty to teach them properly, train them, and encourage them in research also. So this conclave is an excellent platform for such a purpose. And youth is my favorite topic, and so I'm very happy that the team ISA Tamil Nadu, led by Dr. Sudarshan and Dr. Kirpakaran, has conceptualized this particular PG conclave to motivate the youth. I place on record the appreciation of Indian Society of Anesthesiologists for all the postgraduates who have worked with bodies made of metal and nerves made of steel during this COVID pandemic. None other than the anesthesia residents have performed better. It's not that I am an anesthesiologist, I am saying so, but God bless you my dear students. God bless you. You have worked remarkably well in this pandemic. We got a lot of students from southern part of India, and the temperature in Rohtak is 6 to 8 degrees, and probably in Tamil Nadu is 22 or 25. So yesterday I was sitting with my postgraduates from southern India and ensured that they bought some woolens. So that, because they are not used to such sort of extreme conditions. So we were just discussing what to pronounce in Tamil and like that. So they made me teach and revise one thing. And with due respect and regard, I say that it means that affection or conveying of feeling of love and expression, na unnai kadalikaran. So that's a feeling of expression for all of you from my side. And heartiest congratulations to the youth and the organizing committee, and wish you best of luck in this conclave. One small suggestion: don't listen to your paper presentations only, listen to others also. Learn the good points about other studies, their oratory skills, and what are the questions the esteemed judges are going to ask you. God bless you, my dear students. God bless you. Long live ISA. Jai Hind. Thank you.
Thank you, sir. Thank you for your blessing. As we are nearing 2020, the Corona has taught us one important lesson to all of us. We have become financially independent to conduct all these academic events. So whenever wherever we can conduct the event. So that is a great lesson this Corona has taught us. So with that small note, we will move on to our academic session now. We have got two great leaders of ISA National as judges today, Dr. Balabhaskar sir and Dr. Divetya sir. And we welcome, on behalf of Tamil Nadu, we welcome both of you, sir. And I hand over this session to our academic committee, Dr. Edward Johnson and Dr. Kumar. Please take over, Dr. Edward.
Thank you, the President. Thank you, Secretary. So, good morning, one and all. So, we are successfully entering the third day of PG Conclave. The first session is the award paper session. We are immensely pleased to have two legendary scholars, Dr. Balabhaskar and Dr. Divetya, with us to judge the best research paper. I welcome Dr. Balabhaskar and Divetya. Both are the past editor of IGE. Without wasting much time, we move on to the first session, award paper competition. The session will be moderated by our President-elect, Dr. Kumar. Over to Dr. Kumar.
Yeah, thank you, sir. Respected national office bearers, today's moderators, our state GC coordinators, Tamil Nadu ISA office bearers, senior members, postgraduates, and my dear colleagues, very good morning to everyone. On behalf of ISA Tamil Nadu, we welcome you all for the Tamil Nadu ISA PG Conclave Award Session and Academic Event, and thanks everyone for all their support. We'll move on to the award paper presentation. We have received around 207 abstracts. In that, original articles were considered for award papers. Our academic coordinator, Dr. Edward Johnson, and myself have selected 8 papers out of the 78 original articles we received, and which will be a live presentation today. So I congratulate all the 8 presenters in this award category. These are the 8 presenters. About the guidelines, the duration of presentation will be 8 minutes, and the presenters are requested not to exceed the allotted time, and discussion will be 4 minutes per paper. The discussion by the judges will follow after each presentation. The presenter is responsible for PowerPoint clarity, audio, video, and live settings during their online presentation. So all are requested to make sure the quality of audio, video, and live settings during their presentation. And if there are any videos in their presentation, they are requested to communicate with the coordinators and our media partner A1 Logics for hassle-free running of the presentation. These all already checked. Is everything in order? The best 3 papers will be given the ISA sponsored cash prize awards, and the rest of the presenters will be honored with the appreciation certificates. The decision of the judges will be final in selection of the top 3 papers for cash prize awards. These are the presentation guidelines. So I request all the presenters not to exceed the timing, 8 minutes. This I invite our judges for today's session. Two senior most academically well enriched, our past editors of IJA, Dr. Balabhaskar sir and Dr. Divetia sir. About Dr. Balabhaskar sir, sir is currently a chairman academic committee ISA National, and he is a professor at Vijayanagar Institute of Medical Science, Bellary. He is a president of ISA National 2019. He was a past editor-in-chief, Indian Journal of Anesthesia from 2013 to 2016, and is currently an editor, Rajiv Gandhi University of Health Sciences, Journal of Medical Sciences and RJMS Medical. And is a member, Board of Postgraduate Studies, Rajiv Gandhi Institute, Bangalore. He is an adjunct professor, KMC Manipal, and his areas of interest are research, guidelines, education. He has more than 50 publications to his credit. With Balabhaskar sir, we have conducted 2014 Madurai ISACon. I was chairman scientific committee at the time, and he was a complete guiding force behind my successful completion of scientific committee in 2014 ISACon. Thank you, Balabhaskar sir, and welcome you, sir, for this award session. Our next judge is Dr. J.V. Divetia sir. He's a professor and head, Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital, Mumbai. He's currently a president of Society of Onco Anesthesia and Perioperative Care. He's a past editor-in-chief, Indian Journal of Anesthesia, past president, All India Difficult Airway Association, past president, Indian Society of Critical Care Medicine. He has more than 140 publications in national and international journals. Divetia sir is well known for his academic feats all over the India and the international forum also. Welcome Dr. Divetia sir for this award session. So we have two excellent and academically very much interested judges to be the judges for today's award paper presentation. So I invite our today's judges to proceed for the session with the introduction, and then we'll invite the candidates to present. Over to judges, please.
Candidates will be in alphabetical order, you just mentioned.
Yeah.
Yeah, we are ready, Dr. Kumar, Divetia sir and myself, we are ready.
Yeah,
Yes, sir. Yes, sir. Welcome, sir. Welcome, sir. You want to give any introduction? You can proceed, sir.
I think we wish all the candidates all the best. And within the limited time, we are trying to assess them. We have got a scoring sheet provided by Dr. Edward Johnson. We will enter all the scores, and the average of the scores will be taken when we want to declare the winners also. Divetia sir.
Yes, sir. Good morning. Thank you very much for this excellent initiative. I just want to wish all the paper presenters all the best. All your hard work is very, very useful in your current, even for this competition and even in your future life. So keep doing good work, and only a few of you can win prizes, but all of you have are winners by taking part in research and trying to do good research. So all the best, and let's start the paper competition.
Thank you, sir. Thank you, sir. So we'll move on to the presentations. The first presenter will be Dr. Aarti Kannuswamy. To reduce the overall bias from everyone, we are not revealed any of the college name or place name. So first presenter will be Dr. Aarti Kannuswamy. Aarti Kannuswamy, please.
Yes,
Your time starts now.
Good morning. The topic for my paper presentation was the effect of goal-directed fluid therapy versus conventional approach to intraoperative fluid administration during major open abdominal surgeries. The fluid therapy is an important point of care in patients undergoing major open abdominal surgery. It is one of the predictors of post-operative mortality and morbidity. Perioperative hemodynamic optimization improves post-operative outcome for patients undergoing high-risk surgery. Inadequate fluid administration can lead to inadequate tissue perfusion. There are a lot of controversies regarding liberal, restrictive, and goal-directed fluid therapy. There is an increasing evidence in the use of goal-directed fluid therapy using dynamic predictors like stroke volume variation, pulse pressure variation, and systolic pressure variation. The study was undertaken to compare goal-directed fluid therapy using flow track with conventional method in patients undergoing major open abdominal surgery. Methodology. The study was conducted in patients aged 30 to 70 years of either gender belonging to ASA 1, 2, 3 and scheduled for major open abdominal surgery like Whipple's procedure, gastrectomy, abdominoperineal resection. Patients were assessed on the day prior to surgery, written consent obtained, nil per oral orders given as per guidelines. In operating room, peripheral IV access was secured, RT line was secured for invasive blood pressure monitoring. In patients of flow track group, that is a goal-directed fluid therapy group, it is connected to flow track sensor through a connected to a Vigilio monitor 3rd generation. General anesthesia with endotracheal tube intubation was done after induction with 2 mg per kg of propofol, 2 microgram per kg of fentanyl, and muscle relaxant vecuronium 0.1 mg per kg. After intubation, mechanical ventilation was initiated using volume control ventilation with a tidal volume of 6 to 8 ml per kg and PEEP of 3 to 5 centimeter of water with respiratory rate set to maintain normocapnia. Standard monitoring included electrocardiography, pulse oximetry, invasive blood pressure monitoring, capnography, temperature monitoring, and urine output. Anesthesia maintained with sevoflurane in a mixture of air and oxygen. Central venous catheter was inserted via right internal jugular vein for the measurement of central venous pressure and fluid administration. In conventional fluid therapy group, the endpoint was to keep the mean arterial pressure ranging between 60 to 90 mmHg with the central venous pressure in the range of 8 to 12 mmHg and urine output of more than 0.5 ml per kg per hour. Maintenance IV infusion in the form of crystalloid was given at a rate of 2 ml per kg per hour to maintain mean arterial pressure in the range of 60 to 90 mmHg with a CVP central venous pressure in the range of 8 to 12 mmHg and urine output in the range of more than 0.5 ml per kg per hour. However, according to hemodynamic monitoring, if mean arterial pressure is less than 65 mmHg or urine output less than 0.5 ml per kg per hour and central venous pressure less than 8 mmHg for more than 20 minutes, a bolus of 200 ml of crystalloids was given. This is the picture which shows the flow track sensor. This is the monitor of the flow track sensor, which includes cardiac index, stroke volume variation, and stroke volume index. In goal-directed fluid therapy group, the baseline stroke volume variation was noted and it was then monitored continuously thereafter, and fluid was administered according to the stroke volume variation. Both cardiac index and stroke volume variation were continuously monitored and recorded every 20 minutes. Maintenance fluid therapy was provided in the form of crystalloid so as to keep the cardiac index of 2.5 L per minute per meter square, stroke volume variation of less than 13% with a mean arterial pressure of more than 65 mmHg. This is the protocol algorithm for goal-directed therapy. If the mean arterial pressure is less than 60 to 90 mmHg, then look for cardiac index. If it is less than 2.5 liter per minute per meter square, then look for stroke volume variation. If it's less than 30%, there is no need to administer additional fluid. If it is more than 30%, then administer additional fluid of 200 ml of crystalloids. If there was a blood loss exceeding allowable blood loss, then blood transfusion was planned. Intraoperative hypothermia was prevented by using body warmer, hotline warmer, heat and moisture exchanger filter. At the end of the procedure, input and output was calculated, then net fluid balance was noted and documented. Results, a total of 10 patients were enrolled, 5 patients to goal-directed therapy group and 5 patients to conventional therapy group. This is the table which shows the demographic data, which included age, gender, height, weight, and BMI. And there was no statistical difference between the two groups in all these categories. This is the table which shows the duration of surgery, and there was no statistical significance between the two groups. This is the bar diagram which shows the administration of intraoperative fluid between the conventional and flow track group, and there was a statistical significance between the two groups, which showing that the goal-directed fluid therapy group received less intraoperative fluid compared to the conventional group with a p-value of less than 0.008. This is the bar diagram which shows the blood products administered between both conventional and flow track group, and there was no statistical significance between the two. This is the bar diagram which shows the urine output between the conventional and flow track group, and the aim was to maintain urine output of more than 0.5 ml per kg per hour, and there was no statistical significance between the two groups. This is the picture which shows the blood loss, and there was no statistical significant difference between the two groups in blood loss. This is the bar diagram which shows the net fluid balance between the conventional and flow track group. The net fluid balance for intraoperative fluid therapy showed that patients in conventional group has received significantly more positive fluid balance compared to the goal-directed fluid therapy group. Discussion. The perioperative fluid management is one of the most debated areas in present-day anesthesia practice. Assessment of adequacy of intravascular volume is of prime importance to prevent hypovolemia and tissue hyperperfusion. The postoperative complication associated with major surgery have a huge impact on long-term mortality. In the study, we have included only major open abdominal surgeries like Whipple's procedure, gastrectomy, abdominal perineal resection, where large fluid shift was expected. Increased extracellular fluid in the bowel can lead to decreased gastrointestinal motility, can lead to gastrointestinal edema, and possibly ileus. Intestinal edema can cause tension at the anastomotic site and may contribute to anastomotic dehiscence. The demographic data, surgical procedure, duration of surgery were all comparable between the groups, and it was shown in the figure. The goal-directed fluid therapy group, guided by the stroke volume variation using flow track, has resulted in a reduced fluid infusion in the intraoperative period. Lin et al. Reported that there was no statistical significance in overall fluid volumes administered intraoperative between the patients with and without GDT. But patients in goal-directed therapy group received significantly higher volume of colloid fluids. Comparison of administration of crystalloids between the groups showed conventional group has received significantly more amount of crystalloids with a mean value of 3,220 ml compared to the goal-directed therapy group. We calculate the net fluid balance by adding up all the fluids infused, that includes crystalloids and blood products, and subtracting all the measurable fluid losses, that is blood loss and urine output. The net fluid balance calculated in conventional group was around 2090 ml and in goal-directed fluid therapy group was around 760 ml with a statistical significance with a p-value of less than 0.008. I conclude my study that the use of goal-directed fluid management using stroke volume variation obtained through a minimally invasive flow track Vigilio results in a lower net fluid balance as compared to the conventional fluid therapy. The limitation of my study was that the sample size was very low, the post-operative monitoring and ICU monitoring was not done, and it is expensive. These are my references. Thank you, sir.
Yeah, thank you. It's on time, and over to judges, sir.
Nicely presented overall, and very concise and up to the point. But I'll be talking about 2-3 technical issues, and I will pass on to Dr. Divetia. First of all, the sample size is quite less. Okay, so one of the major problems for us is even you spoke about statistical validation also. So it's difficult to accept statistics and validation in terms of even the p-value when you got only such a little sample size. So is it a pilot study or it's just a starting of this study you have done?
So it's a pilot study, sir.
Pilot study.
Yes, sir.
But is it represented in your title that it's a pilot study?
No, sir.
It should be open and clear.
Okay, sir.
So if it is a pilot study, we will take the discussion along those lines only. Because we are more interested in the sample size. Apart from the academic aspect, we are also, when students like you present the papers, no, the technicalities and the research methodology is very important. Okay. So that includes the sample size calculation and some mention about the type of statistical tests that have been used that has not been done. And one more thing that is missing is you should not just stick to your own outcomes. You should also talk about other researches which have been carried out in the past. Okay, you have just put about 3 references in the end, but what are they and how do they relate to your study? How good is your study compared to them, or limitations of your study compared to them? So these are the ones also which should be highlighted. Okay, and small things like even the basic things like getting the consent and any randomization was done to avoid the bias, allocation concealment. So these are some of the very important things that will help you to score the marks in a final like this. Okay, these are very important one. And why was the blood loss noted? What you wanted to study?
Sir, to calculate the output, sir, to calculate the net fluid balance, we noted the blood loss, sir.
Output only, but you expect some, difference in the blood loss and try to calculate that? No.
Sir, if blood loss is more, then there is more chance for intraoperative hypotension. So to avoid that, we calculated blood loss also, sir.
Okay. Sir, Divetia, sir.
So good morning, Dr. Aarti. Very nice topic that you chose, a very challenging study. So 1 or 2 technical points like Balabhaskar sir mentioned, your ethics approval and whether your study was registered with CTRI or some registry, that needs to be mentioned.
Okay, sir.
Now I noticed that your tidal volume was 6 mils per kilo.
6 to 8 ml per kg, sir.
So it was less than 8 ml per kilo, right?
Yes, sir.
So when the tidal volume is less than, say, 8 ml per kilo, is the stroke volume variation a reliable measure of fluid responsiveness?
Yes, sir. There will be a change in stroke volume variation, sir, in compared to ventilation.
But the value of 13% is not necessarily valid when your stroke, when your tidal volume is less than 8 ml per kilo. Right?
Okay, sir.
Okay. The other thing is, I also noticed that your urine output in the flow track group,
Yes, sir.
the mean was 0.45.
Yes, sir.
It is less than the target of 0.5.
Okay, sir.
So how do you explain that? And do you think that's why you gave less fluid? And so is that it's not actually in keeping with the protocol, right? The protocol also have a urine output of more than 0.5 ml per kilo.
Yes, sir.
So what is the explanation for that? Is there something? Is there one or two values patients which skewed the thing, or what is it?
We want to maintain the fluid balance, urine output more than 0.5 ml, sir. And with the goal-directed fluid therapy, we could able to maintain the fluid balance more than 0.5 ml per kg, sir.
But your mean, madam, was 0.45. That means there were patients who were less than 0.5.
Okay, sir.
Okay. Lastly, if you are to do this study to have a more meaningful endpoint, right now your only outcome is fluid balance and
Yes,
total
sir.
fluid given. What would be a good outcome that you would like to study in future? If you're doing this study further, like this may be a pilot study, but if you want to do this, what outcomes would you really want to study?
Sir, I want to add on post-operative monitoring, that is ICU monitoring for 24 hours, sir. I want to include all the investigation done post-operatively. I want to look for the any chance for acute kidney injury post-operatively, so that look for the outcome of the flow track groups, goal-directed fluid therapy groups, sir.
Would you want to include surgical outcomes, since you said there's edema and anastomotic?
Yes, sir. I want to look for surgical outcome also. Yes, sir. Anastomotic leak in any patients I have to monitor, sir.
Okay. Okay. Thank you, Aarti. All the best.
Thank you, sir.
Thank you, sir. Can we move on to next presentation, sir?
Yes, please. Yes, sir.
Okay, sir. The next presenter is Dr. Chandresh. Over to Dr. Chandresh.
Yes. Good morning, sir. I'm Dr. Chandresh, second year anesthesia PG. I'm here to present the paper on compliance of cardiopulmonary resuscitation during in-hospital cardiac arrest in the teaching institutions. I have registered in the CTRI. Introduction. The guidelines for cardiopulmonary resuscitation emphasize the importance of performance of high-quality CPR in determining the survival after cardiac arrest. But in clinical practices, the quality and the parameter of CPR is not routinely measured. So the measurement of CPR quality during actual cardiac arrest, giving feedback to the rescuers, and debriefing may improve CPR quality at subsequent cardiac arrest. So my aim of the study is to measure the multiple parameters of in-hospital CPR quality and to determine the compliance with American Heart Association guidelines. In the objective of the study, the primary objective is compliance of cardiac resuscitation, including initial analyzation, resuscitation procedures, CPR assessment, and resuscitation outcomes. And the secondary objective is compliance on debriefing and audit outcome. This is actually a retrospective observational analysis done in patients who experienced in-hospital cardiac arrest between 1st January 2019 and 31st January 2019. My inclusion criteria for my study is all code blue victims. The code blue victims age between 20 and 80 years, and I have excluded in the pediatric population and victim with impending cardiac arrest where there's a sign of spontaneous circulations. So the methodology, the result of compliance of cardiopulmonary resuscitation during in-hospital cardiac arrest, after the auditing for every month, we are divided into a group of protocol deviation, resources issues, and documentation issues. Overall, in the year of 2019, 248 cases of code blue have been called, and in that, the properly complete document audited was 98. In that, the protocol deviation, resource issues, and documentation issues were noted down. This department-wise statistic where the code blue was called, where the maximum code blues were called in medicine department, followed by neurology, then followed by pulmonology and nephrology, owing to the severity of illness. The sex-wise distribution, there's a slight male predominance. We are coming to the the protocol deviation, that is 37.34% noted. Here we divided it into inadequate CPR duration, delay in CPR initiation, cardiac rhythm not mentioned, earlier administration of adrenaline or amidron, delayed or misadministration of prestation drug, administration of wrong drug or dosage, inadequate drug spacing, inappropriate defibrillation, prolonged CPR to defibrillation ratio, and reversible causes not addressed. Here in the protocol deviation, a major part is played by the reversible causes, which is not addressed. Documentation parameters, the CPR quality documentation not done, clinical event at the time of code not specified, events leading to cardiac arrest not addressed, inappropriate defibrillation joule delivery, code blue members not documented, monitoring of outcome measures, pre-CPR assessment form not filled properly, inadequate airway and ventilation management, time of death not notified, and location of war not documented early. Here, the inappropriate defibrillation joule delivery plays a major role in this deviation. And the resources parameters, CPR audit form not received in the ward, delay in the arrival of code blue team, improper laryngoscopic functioning, unavailability of appropriate size endotracheal tube, bougie unavailability in the crash cart, misplaced or unavailable of emergency drugs in cash tray, malfunctioning of defibrillator, failure of suction device, and defibrillating not done. In this, the malfunctioning of defibrillator played a major role, which is 4%. So as my recommendation or conclusion, it's a teamwork. There should meticulous care should be taken to document the cardiac event. They manage the cardiac arrest in the algorithmic manner, and we should check the availability of resources, and we should maintain a good dynamic teamwork. Actually, a debriefing helped to decrease the mortality in cardiac arrest victims. To conclude, the auditing was done to improve the quality of healthcare in the resuscitation measures, and not to focus on the pitfall of cardiopulmonary resuscitations. Here are my references, sir. Thank you.
Thank you, Dr. Chandresh, for being on time. Thank you. Over to judges, please.
Chandresh.
Yes, sir. Yes, sir.
You didn't utilize your whole time?
Sir?
You didn't utilize allotted time? Allotted time was 8 minutes.
Yeah, you didn't utilize full time.
So there must be some reasons, I also suppose.
Yes,
for example, even if it is something like this, an audit, it's always better to highlight about similar research done elsewhere. Okay, so this also depends upon the setup, the facilities available, okay, and different countries. So even India is such a vast country. For example, you can have the best setups, and we can have the setups with minimal facilities also. So even the previous speaker also, we had that problem because there was no discussion about the related researches which are conducted in the past. Okay? So we cannot, even if I do something, I cannot claim that I have done the best, I am the right person and I have done the right thing. So you must always cite previous research, say how different it is and how good or how bad it is. So I'm just repeating the sentences only for you to understand. Okay, that's the one thing. Secondly, also in terms of, when you talk about human resources, you should also be talking about the training levels. If I missed, I don't know, but did you talk about the training levels of the healthcare group?
No, sir.
So that should have been, that's very valid, because even ISA, we are insisting upon our own guidelines, CPR guidelines across the country and trying to implement everywhere. So that has been missing there. Very important consideration, and that everybody knows. And when you committed about inadequate CPR time,
yes,
as something by definition to be less than 30 minutes.
30 minutes.
Is it your own definition, or you have picked up from previous research or a publication?
Sir, I took from, it's not my own definition, sir. We follow here of minimum of 30 minutes of CPR, at least 30 minutes of CPR, and more than that depends upon the patient and the outcomes. So here we follow a minimum of 30 minutes of CPR, sir.
Okay, so that is not normally acceptable. You should be able to explain why that 30 minutes. Why not 35 minutes? Why not 25 minutes? Can you explain?
Sir, no.
Sir, give it a okay.
So Chandresh, this is an audit, right? So
yes, sir.
A good effort to sort of know what you're doing with CPR. Now, just forgive me if I've missed it, but you had about 245 code blue comments.
Yes, sir. Code blue comes.
And how many did you analyze? 98?
Sir, actually, every month we used to do an audit, sir. We have received all the audit forms, which will be coming from various departments, and we will do a monthly audit with the team leaders of anesthesiology, critical care medicine, and medicine people, everybody, sir. In that, the properly documented, the code blue was not falsely called. All that will be eliminated, sir. The patient will have a sinus rhythm, but code blue have been falsely called. All that will be kept apart separately, sir. The other documentations, which is properly fully documented, fully signed, and thing will be taken into account, and we will see the pitfall in that, sir. Any deviations?
Those were 98.
Yes, sir.
So, were there any forms where there were genuine code blues with the full-blown cardiac arrest, in whom documentation was not adequate and were not analyzed?
The documentation, no, sir. We have seen all the documents, sir.
No. So when you say that 245 code blues and only 98 analyzed, then we have to know what is the sequence. Something like a consort diagram. 245 code blues. Out of them, so many were respiratory arrests, so many had this thing, so many were cardiac arrests.
Yes, sir.
Right? Out of those cardiac arrests, how many had full documentation? Out of those with full documentation, how many were analyzed? Or how many had inadequate documentation? How many had complete documentation? And how many were analyzed? So we have some idea, but otherwise it sounds a little skewed to say you analyze only 98 out of 245. Okay. Now, did you have end-tidal carbon dioxide monitoring in your list of parameters?
No, sir. No, sir. We are not doing it routinely, sir.
No, don't you think it should be done routinely?
Yes, sir. Yes, sir. It should be done routinely, sir.
Because apart, it's the only real indicator of quality of chest compressions that you can, because you can't measure 2.5 inches, but you can measure the end-tidal CO2. Plus tell you about tube placement, right?
Yes, sir.
Okay. Now, this is an audit.
Yes, sir.
And you found so many some lapses here and there.
Yes, sir.
So, an audit is only one part of your quality improvement process.
Yes, sir.
So what measures have you taken after your audit to improve your performance of your code blue teams?
Sir, after this audit, after I'm doing this audit, this report I have sent to all the code blue team leaders, sir, anesthesiologists, medicine, regards stating that this all the pitfalls we are facing. Basically, I just submitted, sir, and I just want to reinforce that, sir. What all we are lagging in our locality.
So, but when did you finish this study? This was January to December 2019.
December 2019, sir.
So now it is 1 year.
Yes, sir.
So what feedback have you had from administration or your... now, I understand you're a second year PG, but obviously there has been someone guiding you.
Yes, sir.
So the important thing is not just to do an audit for the sake of doing an audit, but you need to complete that audit loop.
Yes, sir.
So do you know if any follow-up action has been taken after this? Because now it's 1 year since you've submitted your report.
Yes, sir. After this, the defibrillator machine number have been increased, sir. The defibrillation machine was properly checked by the nursing superintendent, sir, periodically.
And there was some comment about the number of joules delivered was wrong and so on. So that is a training issue.
Yes, sir.
Teaching and training issue. So how have you addressed that?
Sir, basically here the basic life support and advanced life cardiac support training have been giving, sir. We are giving here for every 6 months. We are selecting. We will select every nursing students, and we'll reinforce them every 6 months, sir. But due to this COVID pandemic, we are not doing that meeting. So I just reinforce that if there is any possibility of doing that again and do the training properly, is there any possibility? I'm just reinforcing that, sir, to the institution. I just asked, sir.
Okay, thank you. Thank you, Dr. Chandresh. All the
best.
Thank you,
sir. Thanks.
Yes, sir. We can go to the next.
Yeah, thank you, Dr. Chandresh. Thank you, sir. The third presenter will be Dr. Gautam. Dr. Gautam, please.
Good morning, all. The topic of my paper presentation is comparison of perception of learning and education among different tier of anesthesiology resident in a current scenario. Introduction. perception of educational environment is a relevant indicator of curriculum implementation success. The learning process is strongly influenced by the way the students perceive the educational experience. It has been shown that at the graduate level, the student perception of learning environment is a better predictor of educational outcomes than the prior achievements at the school level. It is also important that the students engage in a deep approach to a learning process, as the professional expectation demands a structured analysis of problems to formulate the solutions. The evaluation of this dimension of learning is a useful tool to aid in the assessment of curriculum implementation in the postgraduate students. The Dundee-Reddy Educational Questionnaire is a questionnaire used to evaluate the educational environment in a medical education. It has been used to diagnose the strengths and weaknesses related to the education environment and to evaluate the impact of the curriculum changes. The aim of my study to assess the perception of learning and education among different year of anesthesiology resident with each domains of the DREAM survey. Methodology: following the informed consent, we include 43 anesthesiology residents across all the years in our department. The confidentiality was maintained by keeping the forms anonymous and having collected by a researcher who was not included in the study. The DREAM questionnaire was collected by them, and a survey of baseline demographic, economic, and educational characteristics was done. The DREAM questionnaire has a set of 5 domains: SPL, the student perception of learning; SPF, the student perception of faculty; SAP, self-academic perception; SPA, student perception of atmosphere; and SSP, social self-perception. Each domain has a set of questions. For example, SPL, the student perception of learning, has a questions like: the teaching is well-focused, the teaching is well-centered, the teaching often encourages the students to participate in the class, the teaching often encourages the student as an active learner. The DREAM questionnaire overall score and the individual domain score were standardized to maintain a consistent scale across analysis, and we have given a score range from 0 to 4. 0 being the lowest and 4 being the highest. We assessed whether the year of residency was associated with the overall standardized DREAM questionnaire score, adjusting for a baseline characteristics like an entrance exam scores, requirement for financial aid, the relationship status, and preference in the teaching faculty. And also, we have calculated and we have analyzed the various characteristics across the years of residency using a non-parametric test by using a Krusal-Wallis test. To measure the significant differences between the DREAM score and its domain values across the year of residency, a p-value of less than 0.05 is considered as statistically significant. My results of the study: the general characteristics. The age of the residents across the 3 years of anesthesiology residents, the age was higher in the final year resident students. And based on the year of residents and based on their loan, it was not statistically significant across the 3 years of anesthesiology residents. Based on the gender distribution, 79.06% of the anesthesiology residents were females, with 20.93% of them were males. Based on their relations, 65% of the anesthesiology residents were single and staying alone, and 14% of them were married and they are staying with the family. Based on their NEET entrance examination score, 46.52% of the residents got their ranks from 20,000 to 29,000, whereas 37.21% got their ranks from 10 to 20,000. Based on their stress levels, we also assess the level of stress during the internship, during the residency programs, and we scale the level of stress from 0 to 5. 35% of the residents were at the scale of 3 on their level of stress, and 10% of the residents were at the scale of 0 in their residency program. This table denotes the overall DREAM questionnaire along with its domain with the year of residency. We also analyzed our results also showed an adequate internal consistency by using a Cronbach alpha value. All the domains in the DREAM score have the Cronbach alpha value of more than 0.7. It indicates that each questions in the DREAM questionnaire is analyzed and assessed with using a same consistency. This table is a primary analysis of the overall DREAM score and its domain. The overall DREAM score was statistically significant across all the years of anesthesiology resident with a p-value of 0.048. And the student perception of learning in the overall DREAM score was statistically significant among the 3 years of anesthesiology resident with a p-value of 0.034. Whereas the other domains in the DREAM questionnaire, like student perception of faculty, student academic self-perception, student perception of atmosphere, and the student social self-perception, was not found to be statistically significant. this discussion, the study shows the result of student perception of learning and education by a different year of anesthesiology resident. The DREAM questionnaire has been extensively used in a medical education to evaluate about the learning environment in a clinically residency program. We also we have included the 3 years of training because each of them were representing the different stages in the educational process. We recognize the learning environment as a continuum that encompasses the social as well as the personal aspect, for which we have included the confounding factors that may affect the perception of learning, including their financial information, the level of stress, the hours of duty, and the number of cases they have done in their duties. The limitation of my study, our study aimed at one specialty which constrains the generalizability of its findings to other specialties. And also, the study data were collected using a self-report questionnaire that offers a subjective assessment of the learning environment, which can be biased findings may have resulted due to self-reported nature of the study. Conclusion, and there was a positive relation among the students' perception of learning and education among the different year of residency in the overall DREAM score. And these are my references, sir. Thank you.
Thank you, Dr. Gautam, for being on time also. Over to judges.
Gautam, it's a novel study.
Yes, sir.
With lot of potential and grossly under-researched in Indian conditions. So that's what I can say. But trying to say that in the end you said it's a limitation that you restricted yourself to anesthesia field. It's not a limitation, that also is an advantage. So don't say it's limitation.
Okay, sir.
Because you are talking as an anesthesia trainee and we are discussing about anesthesia as a faculty.
Okay, sir.
So it's a good thing. We are getting some information from among the anesthesia residents. So this information would be useful when you, for example, if passed on to your administration, if it is passed on to even higher levels in the university and all, it would be very useful.
Okay.
So don't take it as a limitation, first of all.
Okay,
So
sir.
that's not correct. We are not going to do the whole, all specialities and 20 to 30 specialities and trying to get the data. That's a bigger project. So that you will not be able to do at this point of time.
Okay, sir.
And second thing is again back to the same comment I keep on making for all the speakers. You should have always compared with, for example, somebody else having done in the medical group.
Okay, sir.
Yes. Okay. So we should be learning. See, the reason we conduct a research like this is it's like a self-assessment in your own institution.
Yes, sir.
Okay. So what is right, what is not right, and what is left to be improved in terms of the interns, the residents.
Yes, sir.
So if there has been a publication from other institutions in India, in anesthesia or otherwise, or in other parts of the world.
Okay, sir.
So these are the ones which you should always be highlighting about. So this again, we have not included any other similar studies being done. Okay, with either similar or dissimilar outcomes. Okay, one points of interest. That's very important.
Okay.
That's one. And anyway, whenever you start a study like this, you should always acknowledge who actually was the pioneer in this particular technique of audit.
Okay, sir.
Okay, when he did it, because it's like an introduction. You introduced the rest of the thing. The general introduction was there in terms of the teaching, learning, and everything. So the technique which you are using, the DREAM technique, you must be highlighting what it is, who introduced it. Okay, generally, what has been the use overall in the first few years.
Okay, sir.
It was introduced. That's very important.
Okay, sir.
And of course, you have mentioned about what is being predictable. Predictable means learning and except for learning and education part being different between the different years of residency. Rest of them were similar.
Yes, sir.
Okay. Can you reason out why it is so? You didn't reason out. You did not tell us why.
Okay, sir.
Discussion must include why that thing was there. Can you tell me that?
Sir, their approach of the learning, the response to that of questions and the learning was different among the first years and the second years when compared to that of final years, sir.
Yeah. Why it is so? Why it should be so? You should also try to guess and research in your mind why it should have been so. Because logically, yeah, somebody is fresh in the first year. definitely he or she may not be able to understand about the system. Okay, second year is the time when they have just come to terms with the whole setup. They have started doing their research, their own thesis, getting close to the juniors, seniors, and all.
Yes, sir.
And beyond second year, you are in second year or third year?
Final year, sir.
Final year. See, final year, by the time you have got total grip over the system and a grip over the faculty also. Is it not? So you get close to the faculty. You are more free to talk to the faculty, get a feedback on your doubts and everything. Understand? So this is the broad aspect I am trying to tell. So we should reason out why some outcome has happened in this particular study. So these are very important. This analysis is very important by you. And of course, you should also be discussing, yes, all of us know that we have got more number of lady PGs nowadays. So does it affect?
Okay, sir.
Their perception, yes, female trainees may have a certain orientation or certain acceptability of what is around them. So something about that we should be talking basically, and about a marriage and you should have highlighted. See, any data you have collected that must be analyzed.
Okay, sir.
So that part also you should be talking about. And level of stress you have written about some sort of grading.
Yes, sir.
But you should already, it cannot be your own grade. In any research, it cannot be your own grade. You should cite some other validated grades which is available.
Okay, sir.
And you talked about the Cronbach alpha score being obtained.
Yes, sir.
You did for this 43 number?
Sir, we
This 43 numbers with the
for each we did the Cronbach alpha scale, sir.
No, in the sense the Cronbach alpha score is basically not required for this questionnaire.
Okay, sir.
It's such a validated and highly used questionnaire. Understand? Widely used. So we don't need to do for that purpose actually. So it is for a fresh preparation of a survey question.
Okay, sir.
You have a ready-made one which you have started using.
Okay, sir. Fine.
Okay? Yes, sir. Debate, sir.
Thank you, sir.
So, Dr. Gautam, this is an unusual and a different topic. Now, tell me, what was the aim of doing this? I mean, what was your goal? If you, what difference were you expecting to see between first year and third year?
Yes, sir. The students' perception of learning in the current scenario, like the online classes, the method of learning and the method of they are gaining the knowledge was different in the first years and the final year students, sir. So I have compared this perception of learning and education for all the 3 years by using and validated questionnaire, sir.
So is it related to the online thing, or is it in general about?
In general, sir. In general.
And so let's say you'd found a difference between first year and third year. What strategies do you have to tackle if there are some, let's say, in perception of learning?
Okay, sir.
If there is a difference between first year and third year.
Okay.
Right? So what? So you had in between first year and second year, right? Between in the perception of learning.
Yes, sir. Yes, sir. First year.
Right. So what? So like Dr. Balavaskar sir asked, what do you think was the reason, and how do you intend to address it?
Yes, sir. The perception of learning for the first years and the final years are different based on many factors, like they are very new to a department. They know not much learning when compared to the top and final years, their relationship status, and their financial aid. All those factors will consider into the play for the first years and the final years, sir. And the final year residents are more, they have some experience about their academics and more knowledge when compared to the top and final years, sir. So the teaching and the purposes of the teaching has to be well centered to all the residents in our group, sir.
So let's put it this way: the goal of teaching is different in first year, and the goal of teaching is different in final year. Right? In first year, you are being taught the basics.
Yes, sir.
In final year, you are being taught the higher stuff. Plus, you're doing thesis and all those kind of things. So, how do you adjust for the difference in goals of teaching, or just the perception?
Like the timing of the teaching, sir, the class timings, the way of teaching, or the faculty who's the persistent topic who's teaching by the faculty, all those will come into the play, sir. whether the residents were on duties on the previous day. All those will come into the place.
Okay, so thank you.
Thank you, sir.
Thank you, sir. Thank you, Dr. Gautam.
Thank you, sir.
And the presentation time is 8 minutes and the discussion time we can go up to 5 minutes, sir.
If you are exceeding, you can plus point out.
Yeah. Okay, sir. No problem, sir. Okay, sir. Thank you, sir. The next presenter is Dr. Krishma. Krishma, go to the first slide.
Just a minute, sir. Good morning, sir. My topic for today is post-COVID duty psychological sequelae in healthcare workers. As of the second half of August 2020, Tamil Nadu had the highest number of COVID cases in our country after Maharashtra. The COVID-19 pandemic had a massive impact on healthcare systems, increasing the risk of psychological distress in health professionals. Why this study? There are several studies at national and international levels recommending the need for psychological reinforcement to healthcare workers affected by untoward effects of COVID-19 pandemic. We would like to assess the relevance of the same in our setting. The study aims at assessing the prevalence of burnout and psychopathological condition in health professionals working in Kanyakumari Government Medical College. Here we included anesthesiologists of our college. It's a cross-sectional observational study with duration of study 6 months. We included anesthesiologists of COVID ICUs. Data is collected through Google Forms. The study has been applied in Clinical Trials Registry, India. Methodology. The Maslow burnout inventory was used as a tool to assess whether healthcare workers were at risk of burnout. Burnout can be defined as a psychological syndrome characterized by chronic exhaustion and ineffectiveness, and it emerges as a response to the presence of highly stressful conditions in the workplace. The MBA is a 22 items questionnaire on a 5-point Likert scale, which assesses the 3 components of burnout syndrome, namely emotional exhaustion, depersonalization, and personal achievement. A high score in the first 2 sections and a low score in the last section may indicate burnout. We also use 2 other scales, depression, anxiety, and distress scale, which assesses the 3 psychological subdimensions of psychological distress, namely depression, anxiety, and stress. Higher values indicate higher psychological distress, and also impact of event scale, which is a self-report questionnaire assessing psychological distress in response to a traumatic event. It includes intrusion, avoidance, and hyperarousal. We included anesthesiologists who worked in COVID ICUs for 36 hours a week and excluded those who were not willing to participate in the study. Parameters monitored include name, age, gender, occupation, work status, medical comorbidities, and psychological comorbidities. This is a Google form which I prepared online. Statistical tests were performed in SPSS version 25. Descriptive variables were described in terms of means and standard deviation. P-value of less than 0.05 was considered significant. Pearson correlation test was used to calculate correlation of 2 continuous variables. In Pearson correlation, values between 0.02 to 0.3 is mild correlation, 0.4 to 0.7 is moderate, and more than 0.7 is good correlation. According to Maslow et al., 1997, cutoff values for moderate and severe emotional exhaustion were scores more than 17 and 27. For moderate and severe depersonalization, scores more than 7 and 13. And for moderate and severe reduced personal accomplishment, scores less than 38 and 21. In DAS scoring, according to Henry and Crawford 2005, clinical levels of depression, anxiety, and stress were detected, identifying values above the 75th percentile. In impact of event scale, cutoff of 9 was used to dichotomize a total score according to Thoresen et al. So a total of 45 healthcare workers participated in my study, of which 60% were females and 40% were males. The mean value of the scores given by anesthesiologists is plotted in this table. Using the validated cutoff values, scores given by anesthesiologists is plotted in this table. Here the x-axis shows Maslow burnout inventory, emotional exhaustion, depersonalization, and personal accomplishment. Y-axis shows the percentage of anesthesiologists who had the symptoms. Here blue denotes moderate symptoms and orange denotes severe symptoms. So from this we can see that moderate amount of emotional exhaustion was seen in 6.7%, severe in 64.4%. Moderate amount of depersonalization was seen in around 20%, severe in 22.2%. Reduced personal accomplishment was seen in around 100%. Here, the x-axis shows DAS scoring, anxiety, depression, and stress, and y-axis shows the percentage of anesthesiologists who had the symptoms. Here, green denotes normal and orange denotes those who had the symptoms. So from this, we can see that anxiety was seen in around 10%, depression in 17.8%, and stress was seen in around 24.4%. Here, x-axis shows IES score and y-axis shows the percentage of anesthesiologists who had the symptoms. Here, green denotes normal and red denotes those who had post-traumatic stress. So from this, we can see that post-traumatic stress was seen in around 37.8%. Here, the scores given by anesthesiologists is compared with Pearson correlation and p-values, and significant Pearson correlation is given in yellow color and significant p-value is given in green color. So from this, we can see that if there is increased fear of infection, there is a moderate risk for developing emotional exhaustion and depersonalization with significant p-values of 0.001 and 0.015 respectively. Also, if there is increased support from friends, there is a reduced risk for developing depersonalization with a negative Pearson correlation value of negative 0.332 and significant p-value of 0.026. So predictors of the components of burnout from my study include fear of infection and support from friends. Here, this graph shows Pearson correlation values. Here, bright red shows good correlation, light red shows moderate correlation, white shows no correlation, light blue shows moderate negative correlation, and dark blue shows good negative correlation. So from this, we can see that if there is increased fear of infection, there is increased risk for developing emotional exhaustion and depersonalization, which are given in bright red. Also, if there is good support from friends, there is a reduced risk for developing depersonalization, which is given in dark blue. Here in the x-axis, it shows DAS scoring, anxiety, depression, and stress, Maslow burnout inventory, emotional exhaustion, depersonalization, personal accomplishment, and IES score. Y-axis shows the percentage of anesthesiologists who had the symptoms. Here, green denotes normal, yellow denotes moderate symptoms, and red denotes severe symptoms. So from this, we can see that anxiety was seen in around 10%, depression in 20%, stress in 30%, moderate amount of emotional exhaustion was seen in around 6%, severe was seen in around 60%, moderate amount of depersonalization was seen in around 20%, severe was seen in around 22.2%, reduced personal accomplishment was seen in around 100%, and post-traumatic stress was seen in around 38%. So results show that severe levels of burnout and psychopathological symptoms had high prevalence. Depression, anxiety, and stress had low prevalence. The prevalence of post-traumatic stress was also low. These results have clear implications for both the professionals' health and efficiency of the healthcare system. From the perspective of the professionals, burnout is associated with increased risk of both physical and psychological long-term detrimental consequences. From the perspective of the healthcare systems, burnout is associated with increase in sick leave, absenteeism, job withdrawal, and poor work efficiency. Limitations. Due to quarantine restrictions, I could not explain the importance of my study in person to the anesthesiologist of my college, so the number of participants that I could get was low. And also, since it's a psychological study, many anesthesiologists were elected to reveal their psychological status and to participate in this study. So to conclude, my study shows that anesthesiologists have a high risk of incurring in burnout or psychological conditions due to the COVID-19 pandemic. Similar study conducted in Italy also showed high levels of burnout among health professionals, with the percentage of burnout being 60%, and in my study, it was 64%. Continuous monitoring and timely treatment of these conditions is needed to preserve the health of the real COVID warriors. Thank you.
Thank you, Dr. Krishma, for being on time. Over to judges, please.
Dr. Krishma.
Yes, sir.
Yeah, nicely done. It is definitely innovative as compared to the routine clinical studies which have been even part of COVID. So all of us have been talking about the issue-related topics, but you have picked up a nice topic related to the psychiatric affection or affliction, possibly of the anesthesiologist. In the sense, there are not too many questions from my point of view, because this is slightly off-field, at least for me, basically. But what I would like to know is, at what point of time the survey was conducted? You got the feedback. In the sense, out of the postgraduates who are participated in this study, given their feedback, for how many days they were part of the ICU duty cycle, how many hours or how many days of ICU work they had undergone, they had taken up. So that's one point. I thought, is it included in your study there?
have included that. I have included only anesthesiologists who work for 36 hours.
36 hours. Hello, please come again, Grishma.
I think we lost her audio.
Okay.
Grishma?
I think she's offline.
She's offline, yeah.
Sir?
Oh, you are there.
Okay.
There must
Sir, in my study, I told that I have included only anesthesiologists who have worked for 36 hours a week, which means only 6 hours a day COVID duty.
Okay, 36 per hour for a week means you are those who have worked beyond 1 week.
Yes, sir. Sir, we are posted in COVID duty for 8 months, sir. Nearly 8 months we were posted.
Right. So we have lost the audio here. So what Dr. Grishma is probably suggesting is had duties for 36 hours a week. Yeah, Grishma, you are back.
Yes, sir.
36 per hours. Hours per week into 8 months. Just want to know, like you picked up those who only work for a week or whole of the 8 months or 5 months or 6 months.
Sir, I picked up all.
Okay. I assume that she has picked up all the patients through and through. Otherwise, you can type out your answer immediately because we can't waste time, Grishma. Yeah.
Okay, good.
Okay.
You can stop her video so that the audio may be improved.
Krishna, you can stop your video and keep audio on.
Audio
Okay,
on.
sir. Okay. Okay.
That is the bandwidth. So you just remove your video and come back.
Yes, sir. I removed my video.
Good. Okay, just to give a clarification, we will not lose time.
Sir, I have included anesthesiologists who work for 36 hours a week, and I included only those who work for 6 to 8 months in COVID duty.
Okay, so probably there must be a link with the duration of total duty hours in terms of that 6 to 7 months, rather than, for example, initial 1 month or 15 days or something like that. Number one. Number two, in the final part of your presentation, you were talking about the implications of this. One of the major implications also is related to the academics. I think you.
Yes, sir.
It was not there, I suppose.
Sir, because of the emotional stress from COVID duty, academics was also badly affected.
No, I understand. The only thing is I did not find it in that last but one slide where you are discussing about the implications of this.
Okay,
right?
sir. Okay, sir.
Okay. So otherwise, there was much of difference. I would need more time to study your paper, not in what I have heard. Sir, Dr. Diveta, sir.
So Grishma, very good idea. And so I just noticed two things in your results. Okay, there was no correlation of your in your burnout scale with contact with COVID and having worked in COVID, right?
Yes, sir. It was included.
Yeah, but so no, when you all those factors there was correlation with your burnout, contact with COVID and having worked in COVID, there was no correlation, but there was a strong correlation with fear of contracting the infection, right?
Yes, sir. Yes, sir.
Do you think that has got more to do with perception and knowledge of how you get the infection, confidence, or whether you had PPE available to you or confidence in PPE, rather than just the having? So, are you understanding my question?
I understand the
Fear of
question.
infection was there, but there was no correlation with actually working in the COVID area or with COVID patients.
Sir, actually, my study included only those who have worked in COVID wards. I did not include those who have not seen. It was an exclusion criteria of my study. I did not include those who did not do COVID duty, sir.
But that was there in your results, right? Worked in COVID, there was no correlation. So working in the area has no correlation. And contact with a COVID patient, obviously all of them were in contact with COVID patients. There was no correlation. But fear of infection was a major factor. So it seems to be that fear is leading to all these psychological issues. So is there some way you can address the fear rather than, so people are working, but they're afraid. And they are afraid probably when they're not working, isn't it? They are afraid of getting it from colleagues in the canteen or while traveling or whatever it is.
Yes, sir.
Or fear of giving it to the family or something. So the fear seems to be the main thing. So how do you address this fear?
Anesthesiologists were really, sir, in our intensive respiratory care unit, all the critically ill COVID positive patients were admitted, and we anesthesiologists were in charge of intubating any COVID positive patient of our in our medical college. So even contact with the COVID positive patient itself is stressful for a medical professional, and dealing with the airway of a critically ill COVID positive patient was really stressful, I feel, sir.
Okay.
Sorry to interrupt, sir. I think we are exceeding the time of discussion, sir.
Thank you. Thank you.
Thank you, sir. Thank you so much. Thanks, Dr. Grishma.
Thank you, sir.
Next, we'll invite Dr. Jallif. Jallif, please.
Good morning, sir.
Please share your slides.
Okay. Good morning, everyone. I'm Dr. Jallif, and my study is about the intraoperative assessment of effects of positive end expiratory pressure compared with zero end expiratory pressure on atelectasis during surgery under general anesthesia using ultrasonography. Any complication that affects the respiratory system of a patient after they undergo anesthesia and surgery is known as postoperative pulmonary complication, or PPC. It leads to increased mortality, morbidity, and healthcare costs. PPC is a combination of pneumonia, ARDS, and pulmonary aspiration. 3/4 of patients who undergo general anesthesia, they develop atelectasis, and this perioperative atelectasis is a key contributor towards the development of postoperative pulmonary complications. Now, many clinical trials have been done to evaluate the use of protective intraoperative ventilation in preventing postoperative pulmonary complications. But the thing is, very few clinical trials have visually confirmed if this intraoperative protective ventilation actually leads to any difference in the atelectasis in the perioperative period. While thoracic CT is considered as the gold standard for assessing atelectasis, ultrasonography is far simpler to use, is widely accessible, less expensive, and it comes without the risk of exposing the patient to ionizing radiation. The aim of my study was to evaluate using ultrasonography whether lung protective ventilation measures reduces perioperative atelectasis. So 52 patients were screened, and 30 patients were found to be eligible for the study based on our inclusion criteria, which were age greater than 18, surgery under general anesthesia with a duration lasting more than 1 hour, ASA grades 1, 2, and 3. The rest of the patients were excluded from the study based on the exclusion criteria, which were patient refusal, BMI greater than 40, ASA grades 4 and 5, previous or present COVID positive patients, post-COVID sequelae, previous intrathoracic surgery, and severe or very severe COPD. So after obtaining informed consent, these 30 patients who were eligible for study were then randomly assigned into 2 different groups. One was the PEEP and recruitment maneuver group with 15 patients, and the other one was the ZEEP or zero end expiratory pressure group with 15 patients. Patients in the PEEP group, they received a PEEP of 7 centimeter water and a recruitment maneuver of 30 centimeter water for 20 seconds every 30 minutes throughout the duration of surgery. Whereas patients in the ZEEP group, they did not receive any recruitment maneuver or PEEP during surgery. Lung ultrasound was performed using Philips Clearview 350 machine using curvilinear probe, and statistical analysis was compiled with SPSS version 26. The area for performing lung ultrasound was divided using the anterior axillary line and posterior axillary line into 3 different zones, the anterior, lateral, and posterior zones. Each of these zones were further divided into an upper quadrant and a lower quadrant, making it a total of 6 quadrants on each side. So there were a total of 12 quadrants that had to be examined for every patient at each time point. So the first ultrasound examination was conducted at time point A, which is as soon as the patient was shifted into the OT. The second ultrasound was conducted right after induction and intubation and before beginning the surgery. The third point of ultrasound was conducted towards the end of surgery before the patient started spontaneous breathing. And the last ultrasound was conducted in the recovery room 15 to 30 minutes after the end of surgery. Lung ultrasonography score, or LUS, was calculated at each time point for all the patients. Now, this scoring system is primarily based on the visualization of B lines on lung ultrasound. This is a lung ultrasonographic image, and the structures that we see here are the ribs. And these dark areas right beneath the ribs, they are the shadows cast by the ribs. And this hyperechoic line that we see between the ribs, that is the pleura. And then these long vertical hyperechoic lines that we can see that is extending from the pleura to the bottom of the screen, these are the B lines. And B lines are nothing but reverberation artifacts seen in ultrasound images. And the presence of up to 3 B lines is considered as normal. Anything more than 3 B lines indicates that there is an underlying lung pathology. This is a short video loop demonstrating the presence of B lines in lung ultrasound. Here we can see lung sliding, which is the movement of pleura during respiration. And these are the hyperechoic B lines that can be seen extending from pleura to the bottom of the screen. And we can also see that the B lines move along with the pleura during respiration. So a score of 0 was given to a quadrant if normal lung sliding was seen with less than 3 B lines, and a score of 1 was given if there were more than 3 B lines. Now, as atelectasis progresses, the B lines, they coalesce together to form thicker B lines, which are known as the coalescent B lines. So if coalescent B lines were visualized, then that quadrant was given a score of 2. If consolidation has set in, then it appears as an irregular patchy image in the ultrasound image, which is known as the Shred sign or the fractal sign. And if this consolidation was seen in any quadrant, it was given a score of 3. So this way, LUS was calculated for each quadrant and then was added up for all 12 quadrants for every patient. So basically, a lower lung ultrasound score denotes normal lung with normal aeration, and a higher lung ultrasonography score denotes a lot of atelectasis with worsening aeration. So in the patient characteristics, there were no significant differences between the two groups when compared for age, PMI, duration of surgery, or postoperative VAS score. Results were calculated using unpaired t-test in SPSS software and is plotted here as a graph. In the x-axis, we have the 4 different time points where ultrasound was conducted, and in the y-axis, we have the mean lung ultrasonography score. So in the preoperative time point, we can see that the mean lung ultrasonography score is almost similar for both the groups, and it's very lower, indicating that it's a normal lung with normal aeration. Immediately after induction and intubation, we can see that the lung ultrasonography score is worsening, indicating that atelectasis has started to set in both the groups. Now, in the group which did not receive any PEEP or recruitment maneuver, we can see that the mean lung ultrasonography score shoots up all the way to 12.1 just before emergence, indicating that the lung aeration has been markedly compromised due to atelectasis. Whereas in the PEEP group, we can see that there is a significantly lower mean lung ultrasound score, denoting that the aeration is pretty good compared to the ZEEP group, and the atelectasis is under control in this group. Whereas in the immediate postoperative period, the mean lung ultrasonography score once again becomes equal in both the groups, indicating that whatever intraoperative protective ventilation was given, it did not have any effect in the immediate postoperative period. So these are again the results with standard deviation values, and this here is a bar graph with standard error bars showing that there is a significant difference right before emergence between the two groups. So in conclusion, intraoperative lung protective ventilation reduces atelectasis compared to zero end expiratory pressure during surgery as assessed by ultrasound, but this reduction in aeration loss does not continue even in the immediate postoperative period. So PEEP during emergence, CPAP postoperatively, early mobilization along with incentive spirometry in the postoperative period might help in prolonging the benefit of this intraoperative protective ventilation into the postoperative period. So these are my references, and a similar study was done by Generu et al. In Vancouver, Canada, and they also found that the intraoperative protective ventilation did not have any effect in the postoperative period, even in the immediate postoperative period. And this lung ultrasonography score was actually devised by Montasese et al. In the year 2017, and then it has been modified and revised, and it also has been validated in multiple randomized controlled trials. Thank you.
Thank you, Dr. Jalif. Over to judges, please.
Jalif, almost 90% of your present was excellent.
Thank you,
why I'm telling 10% is, yes, you try to make it up by talking in the reference slide. So I think you realized that another 1 or 2 material would have been important, in the sense talking about the other researchers also. So that should have been taken up as a separate slide, and you could have discussed. Again, same thing. Okay, you should always go back to what has been done already and review it. Okay. And why I said almost 90% good was your introduction was very good. That was lacking in some of the speakers, because introduction part shall always cite a important related article, which is very important, particular to the research project. That's very important. And your methodology was also very good in terms of illustrations also. Details about the ultrasound technique and the machines and use of video. So I would be happy generally when the PDs come up with videos and also some sort of even images, even trying to talk about the monitoring, just showing a monitor with all the readings also would be good enough, because we do not waste time talking about everything there. And sample size is one limitation here, basically. Okay, so there is probably undersampling. So you must be discussing about how the sample size was obtained. And because if the sample size is inadequate, we'll not be able to statistically validate the things. Okay, even though we have talked about some of those tests, it's not possible for us to accept them. Even if when you send it for publication, that's a problem. What was, before I pass on to Dr. Divetia, because he is an active ICU specialist, just wanted to know, you have taken a point pre-induction, immediate post-induction, and at emergence and later. So post-induction to emergence, there has not been any scoring that has been done, right?
No, sir, we did not do any scoring.
Because the average length of the procedure, the invasiveness of the procedure, and the position of the patient must be commented upon, because we have got physiological influences which could precipitate or accentuate the risk of atelectasis. So, as a part of methodology, we must specifically say this is the position of the patient at this point of time, and there are intraoperative confounders. That includes the length of the procedure, the invasiveness of the procedure, which also would have some sort of bearing on the outcomes related to the atelectasis. So that's the one thing which I wanted to know.
Okay.
I will pass on to Dr. Divetia, sir.
Okay, so I think there were some good positives in your presentation, which I think even the other PGs can note is the use of confidence of error bars to denote confidence intervals in your graphs. So that's, I think, very important, and you've done that. Okay. Now, yes, lung ultrasound score initially was devised for ARDS, and that's why the focus on B lines.
Yes, sir.
And initially you got small B lines, and you got coalescent B lines, and then consolidation.
Yes.
And consolidation gets a score of 3 in ARDS. But in atelectasis, I know you've given a reference, and I haven't had time to look it up. But is this, do you think you're overestimating the amount of atelectasis by giving a score of 3 right away to all these patients?
No,
They've
sir.
got some evidence of lung shedding and consolidation.
The other signs of consolidation would be hepatization of the lungs, which was not seen.
Right.
Moreover,
Dynamic air bronchograms?
no, sir. The most we visualized was the coalescent B lines, because the duration of surgery was not very long. The average duration of surgery was around 120 minutes for both the groups. So maybe if the duration of surgery was prolonged in oncological surgeries, maybe we would have seen more consolidation. And
okay. If you had to take this study forward, what would you do? One is you looked at atelectasis and the effect of lung recruitment maneuvers and PEEP. But if you take this forward, what would you really want to see?
So in this study, we just analyzed the normal healthy lung adults. So going forward, I would like to also include patients with lung pathology and also obese patients, and see how this PEEP and recruitment maneuver compares.
What outcome would you like to see? What outcome would you like to see apart from ultrasound findings? I mean, ultimately, the aim is what?
Ultimate aim is to prevent the postoperative pulmonary complications in patients who are undergoing long duration of surgery, sir.
So I think that should be your endpoint, and that you can maybe then use ultrasound as one of the things which may help you determine whether we can predict post-op pulmonary complications. Okay, thank you.
Thank you, sir.
Thank you. Thank you, sir. Thank you, sir. Thanks, Dr. Jalif. We'll move on to the next presentation. The next presentation is by Dr. Joy John. Joy John, please.
Unmute yourself. Joy John.
Yes, sir. Okay. Good morning to one and all present here. I am Dr. Joy John. I am presenting a topic on intubation using CMAC video laryngoscope with different curvature of stiletted endotracheal tube in an airway simulator, a mannequin study to determine the ease of intubation. Introduction. As we all know, CMAC video laryngoscope is a novel intubation device that incorporates a camera system at the end of its blade, thereby facilitating a view of glottis without alignment of the oral, pharyngeal, and tracheal axis. It retains the modified Macintosh blade. Though its use has been more common right now, the optimal stillet shape and configuration for its use is not known properly. Therefore, this study is to determine the optimal stillet strategy for the use of CMAC intubation. The CMAC video laryngoscope, which I used in my study, which consists of size 4 D blade. Aim of the study is to find the test curvature, which allows easy tracheal intubation using CMAC video laryngoscope. The primary objective was to find the time taken to intubate using 3 different curvatures of stiletted endotracheal tube, and secondary objectives were to find the ease of intubation and percentage of first attempt intubation failure. Sample size taken was 30 participants, and the study design was randomized crossover study. The study participants were anesthesiology residents. It's an airway simulation mannequin which I used in my study. It is a normal airway adult mannequin. Methodology: 30 anesthesiology residents who had experience in normal laryngoscopy were allocated into 3 groups. Group A consists of residents who had no experience in performing CMAC video laryngoscopy, whereas Group B consists of residents who had up to 10 CMAC laryngoscopy experience, and Group C consists of residents who had experience greater than 10 CMAC laryngoscopy intubation. The resident in each group was given a brief standardized demonstration and one practice CMAC intubation. Hello, sir. One practice CMAC intubation with each stiletto configuration on a mannequin with an anatomical normal airway. All intubations were performed with 7-size Cortex cuff endotracheal tube so that it is standardized. Before each intubation attempt, the tracheal tube was lubricated.
Not audible.
Not audible, sir. Before each intubation attempt, the tracheal tube was lubricated with lignocaine gel. The 3 stiletto strategies which was examined in my study was 80-degree angulated stiletto, 100-degree angulated stiletto, or also known as hockey stick shaped stiletto, and 120-degree angulated stiletto. This angulation was created 8 centimeters from the distal tip of 7-size cuff endotracheal tube. As you all can see, I took boards and made 3 different angles of 80-degree, 100, and 120-degree, so that before each intubation attempt, the angulation could be rechecked easily. The primary endpoint of my study was to find the duration of successful tracheal intubation, which is defined as the time taken between introducing the blade of laryngoscopy and until the laryngoscopy blade is until the endotracheal tube is seen passing through the vocal cord. A failed intubation attempt is defined as an attempt in which trachea was not intubated within 60 seconds with maximum of 3 attempts. And the percentage of glottic opening and coronary ligand grading was seen by an investigator, unblinded investigator, so that there was no bias in the adequacy of laryngoscopy. At the end of each scenario, participants were asked to score the ease level on a visual analog scale ranging from 1 to 5, that is from very difficult to very easy. Statistical analysis: the comparison of time taken for intubation was done with the help of one-way ANOVA test, and the ease of intubation was done with Kruskal-Wallis test. P-value less than 0.05 was considered to be statistically significant. Coming to results, this is a table showing mean time taken for the tracheal tube intubation. Here, if you notice that in all 3 groups, the time taken by 100-degree slit intubation is lesser when compared to 80-degree and 120-degree. This is a table showing 100-degree slit intubation has consumed lesser time when compared to 80-degree and 120-degree in all 3 groups. This is a table explaining, showing the comparison of median of the ease of intubation. Here it shows 100-degree slit intubation is found to be very easy in all 3 groups, whereas 80-degree was the most difficult one, and 120-degree slitted intubation was neither easy nor difficult. The graph explaining the ease of intubation, which represents 100-degree slit intubation, was found to be very easy in all 3 groups. Coming to first attempt intubation failure, the failure percentage in 80-degree slit intubation was 46.6%, whereas in 100-degree it was 6.6%, and 120-degree it was 13.3%, showing that 80-degree slit intubation had more failure rate in its first attempt. Coming to result, it is observed from the study that the time taken by 100-degree slit intubation is lesser in all 3 groups. The participants with more experience in CMAC laryngoscopy required lesser time of intubation. The 100-degree slit intubation was much easier than other 2 configurations. The failure percentage of first attempt slit intubation was more with 80-degree slit intubation than the other 2 slit configurations. Discussion: as we all know, the art of this successful intubation incorporates the best strategy and the technique of intubation Few other similar studies compared or as follows. This is a study published in the Authors Journal compilation in the Association of Anesthetists of Great Britain and Ireland in 2010. Here, they compared 4 Stillett strategy and observed that the use of Stillett conferred no advantage in easy laryngoscopy, whereas in difficult laryngoscopy situation, hockey stick shape or 100-degree performed best, as we observed in our study. This is another study done at Amirda University, Kerala, where they compared 60-degree slatted endotracheal tube intubation with bougie intubation to find the ease of intubation in CMAC laryngoscopy in 2018. Here, they concluded that 60-degree slatted endotracheal tube is found to be easier and faster than bougie intubation when used with CMAC video laryngoscopy. The advantage of this study is that it was conducted on patients, giving a better reliable result than a mannequin-based study. But the disadvantage was they did not compare other Stillett configuration as we did in our study. Limitations of our study: it is a single-blinded study where only participants were blinded. Since it's a mannequin-based study, the intervention performed might have differed from real-world application, having complications like dental damage, mucosal hemorrhage, injury to larynx, subcutaneous emphysema, hemodynamic variations were not analyzed. Conclusion: I conclude that the best Stillett angulation, which allows easy tracheal intubation using CMAC video laryngoscope, is hockey stick shape 100-degree angulated Stillett intubation, which shows lesser time, more ease, and lesser chance of intubation failure in all participants, invariable of their experience. These are my references. Thank you.
Thank you, Dr. Daijan. And over to judges, please. Sir, please unmute, sir. Balavaskar, sir.
Sorry.
Okay.
The whole of the presentation is almost as per the basic structure of the presentation. You have covered from the introduction to the references, all the points, including methodology and statistics, have been good. Congratulations. I have got some issues to be talking about here, because this is mainly a study. So there are limitations, as you mentioned in the last but one slide. This because one of the major determinants in practice is the Mallampatty's airway status, mainly because we are talking about laryngoscopy. So that part we are not able to consider at all. So trying to talk about Stillett with angulation with a video laryngoscope, and we don't have a Mallampatty scoring being assessed for the patient. So that's one of the limitations, basically. And overall, as many of us know, the mannequins can never mimic the humans. Either they are too easy for intubation and are too difficult for intubation. Depends upon the supplies which you have got. And if it is overused and abused, sometimes, some of the structures are also damaged. So even trying to talk about Cormac-Lehane is also very, it's not useful in this setting. Because you were mentioning about Cormac-Lehane and all. So we talking about Cormac-Lehane or a Pogo score with a video laryngoscope. There are limitations in everything. So that we must definitely be dealing with. And in a live case, we also talk about the use of various maneuvers. Okay, apart from using a Stillett or bougie, we also need certain external maneuvers, an assistant and all. So these things can also be probably use of external laryngeal maneuver. Maybe you are not encountered or you are not included in the methodology. So that, yeah.
So I have not included external laryngeal manipulation, sir. It was like basically for studies like if there is a RTA and a patient is supposed to have an supposed to have a cervical spine injury or a patient with a cervical collar, so that there is no sniffing position is not required. So without any manipulation of the neck or head, it is done. So
that's true. No, I am not totally objecting to your not including. Only thing is, when we take it into discussion, your presentation, when we take it into discussion, we are going to say like this. So generally, when you use video laryngoscopy, so these are the ones which are frequently used. We need external laryngeal manipulation. We need some sort of help and accessories, and these would be reduced possibly with use of, you want to justify use of the 100-degree
Stillett intubation.
That's how you take it forward in the discussion. Okay, and very first attempt failure, I have not heard. We talk about first attempt success rate.
Yes, sir.
I don't know what made you. I don't know. Our previous researchers have also would have talked about it. So because we are concerned about success of intubation.
of intubation.
We have raised a definition of a first attempts
failure rate.
Let us be positive and optimistic. So we should be telling, yes, in first attempt, 70% could do, 80% could do, or 90% could do. So that's more important as a technical aspect.
Yes, sir.
And overall, the position of the head and neck is also difficult to be, talking about. So did you mention about that?
Yes, sir. I have mentioned, sir.
Okay, thank you, sir. Give it, sir.
So, what was the type of blade you were using with the CMAC?
I used laryngoscopy D blade, sir.
Which one?
D blade, laryngoscopy D blade, D-shaped blade, sir. 4 size.
You're using the D blade, hyperangulated D blade.
Yes, sir. Yes, sir.
Okay. Okay, so no more questions for you. Thank you. It was a good presentation.
Thank you, sir.
Thank you, Dr. Joy-John. Good presentation. And we'll move on to the next presenter, Dr. Ram Sugashini. Dr. Ram Sugashini, please.
Good morning, sir. I'm sharing my screen, sir.
Yeah, please.
The topic for my paper presentation is a comparative study of the changes in arterial blood gases induced by applying low tidal volume with PEEP ventilation versus conventional ventilation strategy in patients undergoing laparoscopic surgery. Introduction. Laparoscopic procedures often result in multiple postoperative benefits, allowing for quicker recovery and shorter hospital stay. However, pneumoperitoneum and the patient positions required for laparoscopy induce pathophysiological changes that complicate anesthetic management by increasing the intra-abdominal pressure and partial pressure of carbon dioxide. It also significantly affects respiratory mechanics such as intraoperative atelectasis, elevated peak inspirative pressure, and plateau pressure, and decreases the respiratory compliance of the respiratory system. Materials and methods. After obtaining the Departmental Ethical Committee approval, study was conducted at Tirunelveli Medical College Hospital in 40 patients undergoing laparoscopic surgeries. The procedure was explained to the patients and informed consent was obtained. Study design was single-centered, prospective, randomized comparative study. Study duration of about 2 months. Inclusion criteria. Patients of ASA status 1 and 2, patients undergoing elective laparoscopic cholecystectomy and laparoscopic appendicectomy surgeries, patients of BMI less than 30 kg per meter square, patient who has given valid informed consent were included in this study. Exclusion criteria, patient not satisfying inclusion criteria, history of hemorrhagic diathesis and clotting disorders, patient suffering from respiratory diseases, renal failure, congestive heart failure were excluded from the study. Study procedure. Patients were advised overnight fasting for 8 hours. All patients were given tablet ranitidine and tablet perenol on the morning of surgery. And all the patients were pre-medicated with injection glycopyrrolate 10 microgram 45 minutes before surgery. After shifting to the theater, right cephalic vein was cannulated using 18 gauge IV cannula and ringer lactate was started. Patients were given injection fentanyl 2 microgram per kg and injection propofol 2 mg per kg and succinylcholine. After adequate relaxation, the patients were intubated with appropriate size endotracheal tube and connected to ventilator. Ventilator settings were set according to the group allocated, Group C and Group L. Group C, it includes the tidal volume of 10 ml per kg and respiratory rate 12 per minute, adjusted between 12 to 14 per minute and PEEP 0. Group L, the tidal volume of 7 ml per kg and respiratory rate 20 per minute with PEEP 6, maintained with an FiO2 of 50%. In both the groups, the EtCO2 level was kept below 50 mm of mercury throughout the procedure. Then we adjusted them into 4 subgroups based on position. Conventional group in the Trundle-and-Bug position, conventional group in the reverse Trundle-and-Bug position, low tidal group in the Trundle-and-Bug position, and low tidal group in the reverse Trundle-and-Bug position. In all groups, inspiratory to expiratory time ratio was 1:2. Anesthesia was maintained with sevoflurane and injection atracurium was given. The magnitude of peak inspiratory pressure and plateau pressure was obtained directly from the ventilator and was recorded 10 minutes before pneumoperitoneum and after 30 minutes after pneumoperitoneum. Arterial blood gas was analyzed at 10 minutes before pneumoperitoneum and 30 minutes after pneumoperitoneum. All hemodynamic parameters such as heart rate, mean arterial pressure, systolic blood pressure, diastolic blood pressure, peripheral oxygen saturation, and EtCO2 were also recorded. Throughout surgery, intra-abdominal pressure was maintained between 10 to 12 mm of mercury. After the surgery is over and adequate respiratory attempts were present, the patient was reversed with injection neostigmine and injection glycopyrrolate. After return of adequate muscle power and return of the patient was extubated with adequate oral suctioning. Results. Comparison among the groups were done by paired t-test and unpaired t-test. Descriptive results were calculated using mean and standard deviation. A p-value of less than 0.05 was considered statistically significant. Data were analyzed with SPSS version 25 and Microsoft Excel.
A total of 20 patients were included in each group, and patient characteristics were similar between both the groups. There were no statistically significant differences between the hemodynamic parameters in both the groups. And all the patients of my study group comes under the age group between 20 to 35 years. And 22 males and 18 females were included in the study. And there was a change in partial pressure of carbon dioxide. In conventional ventilation, there was a significant rise in partial pressure of arterial carbon dioxide in both the positions. And in low tidal volume with PEEP ventilation group, there is no significant rise in both positions. And partial pressure of oxygen, there was a decrease in partial pressure of oxygen 30 minutes after pneumoperitoneum in both the groups at all positions. And there was no significant change in bicarbonate value before and after pneumoperitoneum in both the groups. In pH value, there was significant fall in pH value in conventional group at both position, and there is no significant fall in low tidal group. There was a rise in peak inspiratory pressure fall seen after in both the group, in both position in tidal and conventional group, and in low PEEP group, low tidal volume with PEEP ventilation group, a rise was seen only in the Trundle and Buck position and not in the reverse Trundle and Buck position. And there was no significant change seen in PEEP plateau pressure. And discussion, according to Muller et al., a rapid rise in partial pressure of carbon dioxide
Lost your connection.
Lost your connection, sir.
Yeah, looks like
Dr.
that.
Ram Sugashini?
Yeah, she's back. Yeah.
Sorry, sir.
Yeah, okay.
According to Muller et al., rapid rise in partial pressure of carbon dioxide and EtCO2 occurs during intraperitoneal insufflation of carbon dioxide, and it reaches its peak at 30 minutes. Razzo et al. Investigated the effects of PEEP on the respiratory system and cardiac function by using transthoracic echocardiography. They showed that PaO2 value is improved in the PEEP group, and both PaCO2 and EtCO2 increased after gas insufflation in the control group. Several ventilatory strategies have been proposed to improve the intraoperative atelectasis and improve arterial oxygenation in laparoscopic surgeries. Current guidance recommend a tidal volume of 6 to 8 ml per kg for the management of patients without risk and 4 to 6 ml per kg in patients with acute lung injury or ARDS. Application of low tidal volume in patients undergoing lower risk elective operation is less evident. So in our low tidal volume with PEEP group, we set tidal volume of 7 ml per kg. In addition to the reduction of tidal volume, increase in level of PEEP is now considered as an integral part of protective ventilation. Lower tidal volume may cause atelectasis, especially if PEEP is low or not used at all. Sufficient PEEP must be used to minimize atelectasis and maintain oxygenation. Although the optimal level of PEEP is still controversial, the use of zero PEEP has been associated with worse outcome, including increased hypoxemia, ventilator-associated pneumonia, and hospital mortality. So we used a tidal volume of 10 versus 7 ml and 6 cm of water PEEP, and positive benefits were seen in partial pressure of carbon dioxide and pH values in low PEEP group. However, partial pressure of oxygen values decreased after pneumoperitoneum in both the groups. In order to prevent this, recruitment maneuver could be done after pneumoperitoneum. In conclusion, application of low tidal volume with PEEP and high respiratory rate during laparoscopic surgeries may be considered to improve good results of arterial blood gases. These are my references, sir. Thank you.
Thank you. Over to judges, please.
Yeah, Dr. Sugashini.
Yes, sir.
You should check your internet speed. Check your internet speed, I said. Okay, doesn't
Yes,
matter. The continuity, very brief delay was there.
Sorry for the inconvenience.
So again, some little bit of technical things I start with. So generally, don't try to use the brand names when you put it in the slides. They are written as Perinorm somewhere. Okay.
Sorry.
Yes, so we put only something it's novel, and there is one brand which is available and big one, something like that. Okay, so don't write Perinorm. And
Yes,
even
sir.
so that's one thing. Some details about sample size calculation would have been useful with the statistical background. Okay.
Yes, sir.
That's the one. And allotment to 4 groups I must apparently be done based upon the type of procedures, right?
Yes, sir.
Laparoscopic procedures. Yeah, because in your result section, a broad outline of the type of procedures that have been done that would have helped us to imagine the physiology during the procedure. That's more important because you have talked about Trendelenburg, reverse Trendelenburg, and with zero pressure and with peace. Okay, so that is one add to the discussion part basically, right?
Yes, sir.
And you have done blood gas at 30 minutes after NEMO, right?
Yes, sir.
Anything? Why in between you are not? You didn't decide to do? What is the basis of doing it at 30 minutes only after initiation of NEMO?
Sir, in previous studies, it showed that after there was a steady rise up until 30 minutes of and it reaches the plateau after 30 minutes only, sir. So we took data after 30 minutes of pneumoperitoneum.
So what if it was a more dangerous rise in between? Was it an intermittent sampling of ABG or was there a radial artery cannula that was put in place?
Intermittent sampling, sir.
We're doing intermittent sampling.
Yes, sir.
Okay. So that's one of the things we should be pondering about. Had there been ideally a cannula, arterial cannula, and doing it also at 15 minutes, for example. Yes, there could be something related to the induction and stabilization of the ventilator parameters. Those things are required, and the patient is being put into position, and NEMO is. So some of the things would be happening. Okay, but we should always be ready to justify why something is done at a certain point of time in a research work. Okay. Then did you discuss about the bicarb values?
Yes, sir. There was no significant change in both the groups in bicarbonate values.
At all the levels? At all
yes,
times?
sir. Yes, sir.
Why is it so? What attribute it to?
Sir, the respiratory rate has been increased in low tidal groups, sir.
Okay. In the conventional group?
In conventional group, the rate was around 12 to 14 per minute with a tidal volume of 10 ml per kg. Sir.
Okay. So there were never any bicarb issues through.
No, sir.
Sir.
What was the exact hypothesis? What were you actually trying to prove with this study?
So in laparoscopic surgeries, we can use a low tidal volume with a PEEP of 6. That won't cause that will improve the arterial blood gas changes, which was producing in the conventional ventilation strategies.
So when you're looking at arterial blood, you're looking at PO2 or CO2?
PaCO2, sir.
So if your minute ventilation is not the same in both groups, how can you compare the PCO2 values? Because in your conventional group, your minute ventilation was 10 ml per kilo into 12. That's 120 ml per kilo. In your PEEP group, this thing was 7 ml per kilo into 20. That's 140 ml per kilo. So you've got unequal minute ventilations in both the groups. How will you explain change in CO2 because of laparoscopy or the ventilation strategy? Because you've got a higher minute ventilation here.
Sir, in a conventional group, it was the respiratory rate was at between 12 to 14 per minute.
Yeah, okay. So I was just reading from abstract, it's 12. Okay. And in but your tidal volume is more, isn't it?
Yes, sir.
It's 10 ml per kilo, and here it's 7 ml per kilo. And so the minute ventilation is 140 in your PEEP group and 120 or 120 in your this thing group.
The respiratory rate was changed between 12 to 14 only.
Okay.
In conventional group.
Okay. So what is the implication of your study?
We can use low tidal volume with increased PEEP setting for laparoscopic surgeries to improve the arterial blood gas changes, like in partial pressure of carbon dioxide and pH values.
Okay, thank you.
Thank you so much.
Thank you, sir. Thank you, Dr. Ram Sugashini. And we will move on to the last presentation by Dr. Srihari Vignesh. Dr. Srihari? Dr. Srihari, are you available?
Unmute yourself, Srihari.
Yes, sir. I am unmuted, sir.
Yeah, please go on.
Okay. Share your slides.
Is it visible, sir?
Yeah, visible. Please go ahead.
Good morning, everyone. This study is about non-invasive pressure-controlled inverse ratio ventilation as rescue therapy to improve hypoxemia in COVID-19 acute respiratory distress syndrome, which is also termed as severe acute hypoxemic respiratory failure. So, non-invasive ventilation is a technique of providing ventilation using a mask or similar device. It reduces inspiratory muscle work, it reduces work of breathing, it causes recruitment of alveoli, it increases the FRC and increases the V/Q ratio. Inverse ratio ventilation is positive pressure ventilation with an IE ratio of greater than 1. This improves oxygenation by increasing the mean airway pressure, causing alveolar recruitment, increasing the intrapulmonary shunt, increasing the VQ mismatch, and decreasing the dead space ventilation. The purpose of the study is inverse ratio ventilation in combination of non-invasive pressure control ventilation with a prolonged inspiratory time used in management of severe ARDS related to COVID-19 to improve the oxygenation. Place and duration of study was Rajiv Gandhi Government General Hospital between May 2020 to October 2020. Inclusion criteria: patients with RT-PCR positive for COVID-19 with acute onset lung injury with bilateral infiltrates on chest X-ray or CT chest. When they are started on non-invasive pressure control ventilation with acute injury, lung injury Murray score indicating lung injury score more than 2.5. Exclusion criteria was patient with hemodynamic compromise, history of bronchial asthma, COPD, and coronary artery disease. Methodology: patients on non-invasive pressure control ventilation with an expiratory tidal volume 4 to 8 ml per kg, plateau pressure up to 30 centimeter of water, high PEEP between 8 to 12 centimeter of water, and FiO2 more than 60%, and still PF ratio was less than 100 and saturation was less than 90, termed as refractory hypoxemia. Ventilatory mode was switched over to pressure control inverse ratio ventilation. P-plat was maintained up. Was limited to 30 centimeters and PEEP was limited to 8 to 12 centimeters. Expiratory tidal volume was limited to 4 to 8 ml per kg. Patient was put in prone position if they are tolerating. ABG was taken before IRV and 24 hours after initiating IRV. Primary outcome was to monitor the hemodynamic changes, to monitor the PF ratio, to monitor the mean airway pressure. Secondary outcome was to monitor the pH, PaCO2, PEEP, expiratory tidal volume, and respiratory rate. So this table shows the patient details along with the Murray score. Murray score more than 2.5 was included into the study as it indicated severe lung injury. This shows the hemodynamic changes. The both heart rate and mean arterial pressure was almost stable before IRV and after initiating IRV. Saturation improved from 83% to 88%. There was increase in respiratory rate. This is a graphical representation of the vital parameters. So this table shows the ABG parameters. There was improvement in pH from 7.29 to 7.33. PF ratio was improved from 79 to 104. And PaCO2, there was improvement from 45.3 to 44.64. This shows the ventilator parameters. The plateau pressure was maintained between 27 to 31. PEEP was maintained between 12 to 15. And mean airway pressure improved from 20 to 25.38. The results: the pressure control IRV was used for 30 patients during the study. IRV was initiated when gas exchange could not be maintained. That is, PF ratio was less than 100 in ABG. So the vital parameters, the heart rate and mean arterial blood pressure was maintained before IRV and after IRV. Saturation, there was improvement from 83 to 88%. There was increase in respiratory rate from 31 to 37. ABG parameters showed improvement in pH from 7.29 to 7.33, PF ratio from 79 to 104, and PaCO2 improved from 45 to 44.6. P-plat was maintained between 27 to 31, PEEP between 12 to 15, and there was improvement in mean airway pressure from 20 to 25. This is a review of literature. A similar study was conducted by Department of Anesthesiology in Tokyo, Japan. 13 patients was included in the analysis from a retrospective review of a collection of patients with ARDS who received IRV from Jan 2007 to May 2014. gas analysis, ventilation and outcome data was collected. IRV was initiated on 4.4 ventilation day when gas exchange could not be maintained. 90-day mortality rate was also calculated. Comparing to this study, here the sample size was more. Non-invasive mode of ventilation was used. It is a prospective study and 90-day mortality was not calculated. Discussion in non-homogeneous lung disease such as acute respiratory distress syndrome, normal compliant lung units are collapsed with non-compliant units. When these lungs are ventilated by positive pressure, the non-compliant units are recruited intermittently while the compliant units suffer from overdistension. The patient oxygenation worsens due to VQ mismatch and intrapulmonary shunting. A combination of severe hypoxia, increased dead space, decreased lung compliance and patient fatigue contributes to the development of ventilatory failure. Precautions to be taken in COVID-19: wearing a full PPE, airway suctioning using closed suctions only. In NIV, using a well-fitting mask, use circuits with 2 limbs, attaching a viral filter at the patient end at expiratory limb. In HFNO, we should ensure correct placement of the cannula and placing a surgical mask over the cannula. Regarding nebulization, if the patient is intubated, use inline nebulizers. If not intubated, use MDI with spacers. Risk of ventilation in COVID-19 ARDS. Ventilator-induced includes atelectrauma, barotrauma, volutrauma, and biotrauma. Oxygen toxicity causing retrodental fibroplasia and reduced surfactant. COVID-related includes potential aerosol generation. Ventilation strategies in ARDS. It includes lung protective strategies, which includes opening the collapsed lung with recruitment maneuver and maintaining the recruited units with appropriate PEEP, preventing the alveolar distension by maintaining a low tidal volume and plateau pressure less than 30, permissive hypercapnia and prone ventilation. Proning was done for patients who require a PEEP more than 10 centimeter and FiO2 more than 60% to maintain a supine oxygen saturation of 90%. Prone position is done by placing the bed and the patient in Trendelenburg at 15 to 30 degrees. The prone position places majority of the lower lobes in the uppermost position. This position reduces the opening pressure, enhance the distribution of ventilation, and reduce the gradient of transpulmonary pressure. Conclusion: hence, pressure-controlled IRV served as a successful bridge to conventional therapy when used as a rescue therapy for severe ARDS related to COVID-19. This also helped to identify the patients who can be effectively managed with NIV, and to increase the FRC in patients who may subsequently require intubation in connection to a ventilator. These are my references. Thank you.
Yeah, thank you, Dr. Srihari.
Yes.
You're on time, and over to judges, please.
Hari.
Yes, sir.
Yeah, it's a novel attempt in COVID patients. That's very important.
Yes.
And again, related to the presentation part, especially the methodology where you are trying to talk about the ventilatory parameters used for the study. So, technical thing. The slide was crowded with too many parameters being entered in that area.
Okay, sir.
Even either you would have known because you are the researcher, but any onlooker or a viewer or the judges would want to know exactly. So that should be clearly visible. So it was too crowded with mention of all the ventilator parameters within that single slide. That was one problem.
Okay, sir.
And even the images, you put up something like a master chart. They are not necessary. And you were also talking about some of the highlights in that particular table. So we are not able to, you were the researcher, but again, as a viewer, I was not able to find out the important data in that particular table. Okay, that's very important. And they carry, even the marks are allotted based on that, apart from your actual research. And even when you send it for publications. So the tables are important, the graphs which are used are important, and even the units of measurement at the simplest one. So that also has to be mentioned, that was missing there. So in terms of the patients being recruited, epidemiologically speaking, what was the stage of the disease, the patients?
And the stage was, it's calculated using the lung injury Murray score, sir.
That's why I prefixed with epidemiologically speaking. I didn't talk about the respiratory intensive care wise thing. I talked about epidemiologically speaking.
Okay, sir.
What was the stage of the disease? Like, were they admitted from the wards with deterioration of the condition, or it was the infective phase or the post-infective phase?
Yes, sir. The patients included was admitted in wards and ICUs, sir. So those who deteriorated within a short period of time and those requiring NIV and those who are not maintained saturation on NIV was included in the study, sir.
So when you have written about rescue in the title,
yes,
so what you said, the IRV with pressure control was used as a rescue therapy
yes,
to improve hypoxemia.
Yes.
So out of the total number of patients you have got, so were you able to clearly say that the patients were able to survive and were discharged? How many in that particular group?
Actually, the follow-up was done for 24 hours, sir. Actually, this is just a bridging therapy, sir. For those who require intubation and those who are suffering from hypoxemia, it just serves as a bridge for the next line treatment, sir.
Now, how many of them went to intubation and how many of them we could avoid intubation?
Out of these patients, more than half of the patients went for intubation, sir. So this helped to increase the FRC for those patients who are intubated also, sir.
No, that's good. No, that's why I said, yes, respiratory parameter wise, you have highlighted what were the improvements with IRV. What I'm trying to ask is actual clinical outcomes. Actual clinical outcome means how many of them could benefit in terms of avoiding intubation or in terms of actual discharge, survival rates.
Actually, survival rate was not calculated in the study, sir.
Because many of us have worked in the field in COVID, so that's the reason. So this is encouraging. The results of the study are encouraging. The outcomes of the study may not be encouraging. So that's the one I want to convey. Because we have always, in any mode, whether it is volume controlled or pressure controlled, if you use this some inverse ratio or something like that, there is always risk of gas trapping. Then again, adverse hemodynamic effects. Everything is always a problem in these patients. Okay.
Yes,
sir. Sir, Divya, sir.
So this was all non-invasive ventilation, right?
It's a non-invasive, sir.
So when you were giving this inverse ratio ventilation, the patient was actually spontaneously breathing at this time?
Yeah, he was spontaneously breathing, sir.
So how can you be sure that the I ratio was 2:1? Because the patient was breathing at his own rate, right?
But we have put them on controlled mode, sir. And we saw whether the patient would synchronize with the control mode, sir.
So how can they synchronize with a 2:1 ventilation?
Based on the mean peak pressures and plateau pressures, we could assure that they are synchronizing, sir. If it is too high, maybe they are not synchronizing, sir.
So were you using pressure See, there are modes which you can use like APRV, but in APRV, the I ratio is very high. It's 8:1, 6:1. But I am just want to know how you actually set your ventilator to in spontaneously breathing patients. How can you be sure it's actually inverse ratio ventilation? Because the patient is breathing at his own I ratio.
Yes, sir. But due to respiratory fatigue, he was not able to completely take his breath, sir. So we need to support. So the support given was more than his spontaneous breath, sir.
So if there were respiratory fatigue, would you advocate inverse ratio ventilation or intubation?
Intubation, sir. But that's what, sir. For intubation, we need to increase the FRC, sir. So regarding before intubation, many patients got arrested during intubation itself, sir, in COVID. So we need to increase the FRC, sir. So this could be a method to increase the FRC to proceed to intubation, sir.
Okay. Okay. Thank you.
Thank you, sir.
Thank you, Dr. Srihari. It was an excellent presentation for all the 8 presenters. They were on time, almost all 8 were on time, perfectly on time. And the clarity of presentation, audio, video settings, everything almost perfect. Thank you very much and congratulating all the 8 presenters. Thank you so much. And judges, Dr. Balbhaskar sir and Dr. Divya sir did a wonderful job. We had a very good discussion with the presenters. Thank you very much, sir, for sparing your valuable time. Thank you, sir. And you both can discuss and you can announce the results within 5 minutes, sir, if you are ready.
Okay,
Before that, we have another announcement by, yeah, please, sir. Please go ahead, sir.
Yeah, we have already The judges will arrive at the winners of this session, both of them jointly. And during the time, we have the other prizes for the last couple of days we have been conducting, the paper and poster presentations from Saturday. So the free paper, e-paper presentation and poster presentation results are ready. To announce the results and the prizes, first I call upon our secretary. First, second, third for each category. And the winners will be announced.
Thank you.
Over to Kripa, please.
Thank you, Sudarshan. Nice presentation and a nice discussion. Thanks for the presenters and both the judges. Now, in the meantime, before we know the winners of this award session, we'll go back to the winners for the general category of e-posters and e-paper. Before that, all your certificates can be downloaded after submitting your feedback form in this website. Please note down this website. From today evening onwards, you can download your certificate. And for the general category e-papers, the prizes are sponsored by, first prize is sponsored by ISA Coimbatore, rupees 5,000. Second prize is sponsored by ISA Madurai, rupees 3,000. And third prize is by ISA Salem branch, rupees 2,000. To announce the winners, I call Dr. Edward Johnson. Please, sir.
Thank you, Thiruvaran. So the much awaited e-paper results are here. The first prize goes to the abstract number 0123, Dr. Padma Rubini from Government Viluppuram Medical College. His topic is comparison between the pre-bifurcation and post-bifurcation approach of ultrasound-guided operative sciatic nerve block in foot and ankle surgeries. Congrats, Padma Rubini. So here is your certificate. Then we move on to the second prize. The second prize goes to the abstract number 0333, Dr. Muhammad Rifan MF from Government Training Medical College. His topic is on evaluation of simple predetermined length insertion technique, that is PET technique, with a conventional method for oral fiber optic intubation, a randomized crossover study. Congratulations, Muhammad. So here is your certificate. Then the third prize goes to the abstract number 0101, Dr. Sandhya Selvaraj from Tirunelveli Medical College. His topic is on a prospective randomized comparative study to evaluate long axis and short axis and medial oblique axis approach of ultrasound guided internal jugular vein cannulation. Congratulations, Sandhya. Thank you. So we move on to the e-poster.
1 minute.
Yes, e-poster results.
Yeah, for to announce the e-poster results.
Yes, till that.
Yeah, 1 minute. The prizes are sponsored by, the first prize is sponsored by ISA Tirunelveli branch, rupees 5,000 rupees for best e-paper. Second prize is sponsored by ISA Tanjavur, rupees 3,000. And third prize is by ISA Chennai branch, rupees 2,000. To announce the winners, now I call upon Dr. Kumar. Kumar, please.
Edward himself will do it. Kumar is computing. Dr. Edward, please continue.
Yeah.
Okay.
Yeah, Edward.
The e-poster prize, first prize goes to Dr. Ranjita Pulikesi Karmadi from Mandya University Medical Sciences, Mandya. His topic is acute fatty liver of pregnancy in postpartum period, a case report. Congrats, Ranjita. So, coming to the second prize, the second prize goes to Dr. Pavitra Palniyappan from Sri Ramachandra Institute of Higher Education and Research. His topic is anesthetic management of child with a single ventricle with pulmonary atresia coming for emergency birth hole tapping. Congratulations, Pavitra. So coming to the third prize, the third prize goes to Dr. Priya M from Madurai Medical College. The topic is a case report on foreign body right intermediate bronchus retrieved using jet ventilation. Congrats, Priya. Thank you, Kriba. Okay.
Thank you all the winners.
Yeah.
Thank you all the winners. Now, you can contact, all the winners are requested to contact me at this email address or at this number. Please note down this number. So then only we can transfer the prize money to your account. So contact with all your bank details to secretary@tamilnadu@gmail.com or send your details by WhatsApp to 9443255799. So the prize for this award papers is fully sponsored by ISA Tamil Nadu. The first prize is ₹10,000 plus holiday stay worth of ₹7,500. That is sponsored by Eco Organic Holiday Resorts. We thank Eco Organic Holiday Resorts for sponsoring this prize. The first prize is totally worth of ₹17,500. The second prize is ₹7,500 and third prize is ₹5,000. This is sponsored by ISA Tamil Nadu.
All these prizes will be announced to the three of these winners of the award paper. The judges, whenever they are ready, they will announce the winners. So those are the prizes. So if the judges are still yet to arrive at the decision, we will still slowly move on with the next session, introducing the next session speakers. By then, I think our judges, both Dr. Divetia and Dr. Balabhaskar, would be ready announcing the results.
Okay.
You can unshare your screen and over to Kumar and Edward, please.
Yeah.
Sir, they are ready. They can announce, sir. Otherwise, they have to leave, sir.
Yeah.
Please note on this number if you need credit hours for this program.
Balabhaskar, sir.
You send your name alone by WhatsApp to this number.
Ready, sir?
Thank you.
Almost ready with mine, but we'll have to average it out, no?
Okay, sir.
Sir, I have sent you your WhatsApp, sir.
So give them some time. Yeah, give them some time, Kumar.
Okay, no problem, no issues.
And then you will introduce the next session speakers. By then, before the next session speaker starts, you will make the grand announcement they can make.
Yeah.
One, Dr. Armugam, Dr. Krishnan, and all the three, Satya, all ready, waiting for the past 20 minutes. So let's not waste their time of having early morning from UK. Just introduce them, and then by then we'll be ready with the results. Go on.
Yes. So we are moving to the next session, the much awaited session, that is overseas career guidance for postgraduates. To show the road to success of overseas training and job placement, we are having three experts here from UK, Professor Dr. Murthy, Professor Dr. Satya, and Professor Dr. Krishnan. So the first speaker is Professor Dr. Armu Murthy. I am glad to introduce him. So Dr. Armu Krishnamurthy is a consultant dermatologist at one of the busy teaching hospital at Leicester. He is the head of the service of his busy tertiary rheumatology unit and regional society advisor for rheumatology at Royal College of Physicians, London. Dr. Murthy is also a honorable associate professor of College of Life Sciences at the University of Leicester. He is very passionate about teaching and training both undergraduate and postgraduate medical students. Dr. Murthy is a senior MRCP clinical examiner and part of MRCP Rheumatology Board at Royal College of Physicians. And Dr. Murthy is extensively involved in clinical research and published his work including COVID-19 and rheumatology. So Dr. Murthy is a honorary international visiting professor of Tamil Nadu Dr. MGR Medical University, Chennai, and he is recently appointed as professor of rheumatology at New Vision University, Georgia. His topic is on road to UK higher medical training. Susan, shall we start?
You can continue. No, you continue introducing the other two speakers as well. We have some time so that all of three of them can be introduced.
So the next speaker is Dr. Satya Francis. He is a consultant anesthetist at University Hospital Leicester NHS Trust and honorary senior lecturer and clinical academic tutor at Leicester Medical School, University of Leicester. She has been a consultant anesthetist for 17 years. Her subspecialty interests of obstetric anesthesia. She has been actively involved in teaching and training. She has been a Royal College of Anesthesia examiner for FRCA for the last 7 years and lead for clinical SOE for final FRCA. She talks on how to succeed in UK anesthesia exams. So the third speaker is Dr. Krishnan Kumar.
Yeah.
Yes.
Third speaker is Dr. Krishnan. Yes, completed his MBBS from Madurai and then DA and MD in Madras. The year 1993, he completed his MD here. Then FRCA in UK from 1999 and FFACS by April 2001. And then he has completed a master degree in medical science, the Leeds in 2004. And his current appointment is consultant anesthetist at Scunthorpe General Hospital, Scunthorpe. And he's also a honorary lecturer at Hull York Medical School and Scunthorpe School and Clemson at NHS Trust. He has a very high teaching experience, clinical supervisor role. He has, to his credit, a lot of publications, audits, and honors. Without wasting much time, I invite Dr. Krishnan as a third speaker to proceed for the session. Over to Edward, sir.
Yes. So we are waiting for the announcement of the newspaper award.
Valvaska sir, ready, sir?
No, just average little bit of mathematics, averaging out.
Okay.
No issues, sir.
Start the first talk, 15 minutes, I think so.
So I welcome Professor Dr. Murthy. Sir, is
Please.
Professor Murthy, sir, are you there?
I'm there.
Murthy, you can start your lecture.
Yeah, can you see my slides?
Not yet. No.
Yeah, we can.
Yes.
You can? Okay.
Yeah.
Yes.
Can I start now? Then or you want?
Yes, please. Yes, please. Yes,
Okay.
please.
Good afternoon, but rather good morning in England. Thank you very much for ISA Tamil Nadu branch to invite me to come and give a talk, which is I'm passionate about my medical education training, both for undergraduate and postgraduate. And thank you for Professor Edward, who eloquently highlighted my background. So without further ado, I'm just going to move on to talk about the higher medical training in United Kingdom, how you get there. Just 1 second, slide's not moving. So the first question you should be asking as a postgraduate or completed postgraduate, why do you want to train in United Kingdom? That's the first question we should be asking before you plan to pursue your career in United Kingdom. So the reason behind that is when I decided to come to United Kingdom some 23 years ago, the National Health Service is one of the largest and greatest care team in the world and wanted to be part of that team. And then the hospitals are very old hospitals, like this is one of my hospital photos where me and Dr. Satya France is working. And it's one of the very busy teaching hospital, and you could get a lot of exposure to most advanced medical management. When you get the clinical training, you also wanted to persuade your postgraduate training, then there is a very good structure of training in England based and guided by an organization called Health Education England. So you work for National Health Service and you train by Health Education England, which has different sort of branches like medicine to anesthesia, surgery, psychiatry, etc.
I think so.
And once you train, you may be part of this elite group with your fellow of Royal College of Physicians or fellow of anesthesia and so on. So you will be a part of a royal degree, which is very well recognized throughout the world. Not only that, you are training. This is our University of Leicester, where you could start teaching medical students from the role as a consultant and also as a trainee doctor or a postgraduate student. So medical students will come to you and then you can able to train them during your career. So I'm an associate professor at the University of Leicester, where I get enough opportunity to teach, mentor medical students. And your training doesn't stop there. You also get exposure to world-class National Institute of Health Research, which is each hospital has a clinical research facility where you will be exposed to do some research. Now, currently, the whole hospital is busy with doing COVID-19 research, and one of the topmost research facilities you can get, and if you're interested in clinical research, you could able to achieve those things. So these are the things which make you to prompt or making you to achieve your ambitions in United Kingdom. Not only that, it's a good city to live in, and this is London, where it's a very clean city everywhere. The life is very good and quality of life is very good. And also you can have a work-life balance very good. That means we all work for 9 to 5. And when you're on call, you're on call. Other time, you just stay on your own time. Weekends are sometimes if you're on call, other times you are relatively free to spend your time with your family and friends. So there will be a very good work-life balance. These are the reasons which you may be thinking about. So the first question you will be asking about why I wanted to come to United Kingdom. That is better training with international recognition and world-class research opportunities, and also adequate pay. The National Health Service pay everybody equally, and then over and above, you are allowed to do private practice where you could earn more. And also if you're achieving more and as year by year, you will be getting reasonable pay, which you can live a very decent life in England. And it's also, as I mentioned, about very good work and personal life balance and better lifestyle. So that's one of the reasons which you may be forced to come to United Kingdom. So now we talked about why, then we need to know how. So when you're asking the question, how do I get into United Kingdom? For that, you need to understand the education system or a training system in United Kingdom. So the dream of postgraduate training, I know there's a lot of people already done postgraduate degree or doing postgraduate degree in India, but you wanted to get further training, it is achievable. When we all left India some 20 years ago, we were not guided by these sort of opportunities, and you people are very lucky to have ISA organizing this sort of an event to motivate you, to help you and encourage you, which is really a commendable position for you now. And if you prepare with advice given by your senior teachers in India, and also we are happy to help you, if you prepare smartly, you could be able to achieve that very easily. So you need to get the right advice and guidance. That's the purpose of this whole event today. So after your qualification in India, what we do is we have 1 year of housemanship or house agency or CRRI. In England, it is 2 years, which is 2 years of foundation training program. When the medical student leave the medical school, they come and work in the hospital for 2 years, which is called foundation training program. Myself and Satya Francis worked as a foundation training program director for the last 5 years. And what we do is we nurture the students coming from the medical school. We have a direct education supervision for them. So that foundation year 1, the General Medical Council give a provisional registration. Foundation year 2, they give a registration with General Medical Council. And it is again regulated by United Kingdom Foundation School. So once you finish the foundation school, then you move on into the stage 2 of your medical training, which is core medical, core surgical, or whichever specialty you wanted to go. Then you need to decide at the level of foundation, and then you need to go and do this training, which is core medical or core surgical. Once you've done that, you go into a specialty training, which is, for example, if you want to get into rheumatology, and then you need to do 5 years of rheumatology training. And after that, you are asked to write an MRCP exit exam. But when you're coming into the stage 3, you are expected to complete your fellowship or membership from the college, particularly Royal College of Physicians or anesthetists, etc. And you come into stage 3, where you will be trained in the specialty which you wanted. After each specialty, you will be expected to sit for an exam called MRCP exit exam, which is for me for MRCP rheumatology. So that will take another few years. So by joining and then you can easily able to reach as a consultant around 9 years time. Bear in mind, all the time you'll be working, all the time you will be also paid. So for that, you need to get a registration into General Medical Council. General Medical Council is the highest authority in England, regulating doctors, ensuring good medical practice. They are the watchdogs for us. So they will maintain the strict good medical practice in day-to-day activities. And any patient can access your General Medical Council number, and they can report you if you are not providing adequate care to them or their family members. So it's very strict regulations. Without GMC registration, you may not be able to work. So it's very strict, and you have to be very careful with that registration. So for getting GMC registration, that's where the starting point started. So to get a registration, the safest route is writing a PLAB, which is called Professional Linguistic Assessment Board exam. To start PLAB or preparing for PLAB, which is an entry for getting your registration into General Medical Council for international medical graduates. The starting point for that is to start showing your proficiency in English. For that, you need to sit for an exam called IELTS. This is an English exam, and there is another exam called Occupational English Test. So one is called International English Language Testing, which gives us scoring, and another one is Occupational English Test. So the Occupational English Test is predominantly for nursing care and also for doctors. However, that has some limitation on it, whereas IELTS has a good scoring, will allow you to work anywhere or showing your proficiency in English across the globe, whereas OET has limitations. Either you can work in Singapore, Australia, New Zealand, and England as well, but whereas the IELTS has an extensive range of cover on that one. So this is called International English Language Testing System. So they will be assessing in 4 components of your proficiency in English, starting with the listening, reading, and writing and speaking. So you all need to score minimum 7 of each one, and you need to get 7.5 out of 9 overall score. I'm sure all these medical graduates from India can easily achieve that one. You have to write IELTS UK academic one for PLAB Tier 2 visa to get. So after that, you need to apply for visa. So that time also the IELTS exam will be counted. So as I said about this is listening, academic, and then general training of reading and writing and speaking. These are the components of that. So listening, it's of any topic. There is a conversation between people set in everyday social context, or it's a monologue set in every medical social context. And then they give you some form of a reading component. They give you a text and from a books or magazine or newspaper, and they're asking you to identify some questions, which is also important to see how quick you are grasping the reading ability. And then you will be given a topic, usually a debate topic. For example, abortion is acceptable or not, or cannabinoids can be used, that sort of things, pros and cons. So you start writing those things. You have to summarize your argument, why you are doing it. There is no right or wrong answer on it, but you could be able to defend why you are saying that and summarize that. Then you will be able to get good marking in the writing. And then moving on into the speaking, there will be examiner will be asking you some questions about yourself, and they're just teasing particularly, something like, for example, cricket, and why do you watch cricket? Why not rugby or etc. That's just teasing your English ability on spot. How do you converse with people? So these are the 4 components, and these OETS exam happens more often whereas IELTS is very less frequent, now particularly about the COVID-19 time. I was told that very few centers are doing it. These results are available very quickly. Both exams within less than a month, you will get the results. So those score is very, very important for you to progress. Okay. So you can get further information. If you Google it, it will come, or this is the email address. Sorry, this is a website address. You can access further information on it. So how do you prepare for IELTS exam? And it is, you can have a website called IELTS Advantage, which you can have some access into, or go to British Library, High Commission Library in Chennai, where, or in the place where you are nearest to British High Commission, you can get access for advice regarding the English exam. And just listen to BBC or some, not the CNN, the BBC, and some debate programs or talking shows and things like that. See how they speak and what they are expecting us to speak like that. It's not very advanced level of English you need to speak, but it should be a very clear, and you need to give gaps between your conversation, and slowly, and you can raise your tone up and down, not monotonous. These are things they will give you in this BBC. And specifically, you stress certain things. You wanted to keep your point. I wanted to give this patient morphine. Then you should stress the morphine clearly. That sort of things, they will be assessing you. So it's easy to prepare. So once you pass IELTS exam and got the score 7.5, then you go into GMC to register yourself writing for PLAB exam, which is a Professional Linguistic Assessment Board exam. The GMC, you can create your own login details, and that will upload your details. Your college will be recognized as one of the colleges. All the government medical colleges in India are recognized. All the colleges recognized by World Health Organization is also recognized. So you need to check your college is recognized or not. And you automatically, when you put your primary qualification and your college, then GMC will say, yeah, you are recognized. Or if not, then you have to go through certain small process, and then you may be able to get registration of your college. And then you register your name for PLAB. The PLAB exam is what I'm going to talk about. My colleagues will be talking about the rest of the thing. PLAB is not a qualification. That's what I wanted to emphasize, people. It is not a qualification. It is an exam which allows you to license to practice in United Kingdom. That means you will be getting a registration with General Medical Council, which is a permanent registration, to start with the limited registration, and it allows you to extend into a permanent registration. That means even you come back to India, you can come back again to UK to practice as a doctor in England. So this is a licensing exam allowing you to practice in United Kingdom. And it's an international exam. Okay, it's not only Indian doctors, right? It's also competitive exam. The scores will be standardized and the mean marks will be taken. So it's not percentage, it's a percentile, which means how many people they want, they'll go through that. So it's an international exam. So you have to compete with other medical graduates. When we took PLAB, that time only 13% they used to give. Yeah, that time all the components happen on the same day. Now you can write English first few months, and then you come for PLAB. The PLAB is also divided into different levels. But what level of standard they expected is basically our undergraduate level, which is here as a foundation training doctor's level. They will expect you a standard. They don't expect you as a postgraduate. They expect your knowledge, testing your knowledge at undergraduate level. So what you need to find about is they are going to test you the good medical practice the General Medical Council wanted the doctors to follow. So make care the patient you as a first concern. Anything is patient safety. Patient safety should not be compromised. So all the questions are tested towards how you deal with these things. And you should be competent and keep your professional knowledge and skills up to date. So there will be questions about, what is the current vaccine for COVID and things like that. and what is indications or that sort of things also they will be. So you need to keep updating your knowledge. And when the patient safety is compromised, what will you do? For example, even I'm a consultant, but if I can be challenged by my foundation doctor if I do something wrong. So all the doctors has a responsibility, and you should maintain a team relationship within your patients and colleagues, and a good partnership with your other people as well. And you should be always open and honest. So you should not be hesitant to say that I don't know the answer for this question. Even I am an educator, I can tell my students, I don't know the answer. I will check, or I will read and come back and tell you. Or he can go and, so that's sort of a honest opinion. At the same time, if you've done some mistake to your patients, you should be in a position to accept. That's called a duty of contour, saying that, apologies, I've done this wrong, but then reflect on learning from that one. So if you go on the General Medical website, Medical Council website, there's a blueprint document on that about lab tests. It's a very big document. I'm not going through that all of them, but it will tells you what are the areas they will be testing you. For example, cardiovascular, they'll be examining if a patient coming with a chest pain, how do you manage? And for example, how do you manage acute myocardial infarction or heart failure? For example, if the patient presenting with fatigue, what are the things you will be considering? So all the scenarios will be there. For example, abdominal pain, abdominal mass, and pediatrics, medicine, surgery, every topics will be covered like that. So if you go on the blueprint, you may be able to identify those things. And psychiatry is another one, which is about, deliberate self-harm, eating problems, and affective mood disorders and psychosis, etc. So that is for the PLAB 1, and they will be assessing your core knowledge of the subjects. And then they will be assessing your skill in part 2, and how do you perform as a doctor, which is the practical exam. So the PLAB containing of part 1, where you assessed with multiple choice questions in your knowledge. And it's the knowledge and skills performance is what they wanted to expect. And then there is a lot of, which I mentioned about the patient safety and quality, and those things they don't want to compromise. And another domain they wanted to say about communication skills. How do you communicate with your patient? How do you communicate with your doctors and team? That is what English knowledge. And not only that, the communication skills is listening to your group, and then how do you advise them? And how do you work as a team? It's a very important theme. Keep on coming, even after you go for interview, they'll be asking questions about team working, communication skill, leadership skills, etc. And always they wanted us to teach and training constantly. So your skills about teaching and training are also important. I give a sample question about this part 1, particularly this is a 22-year-old man, acute painful red eye with a blurring of vision. Similar episode 1 year ago, has episodic back pain and stiffness. What is the single most likely cause of red eye, which is what they will asking about, uveitis and etc. And you given 4 answers, you eliminate most of the time, 3 answers will be easily eliminated. Between 2 answers, you may struggle, but if your knowledge is strong, then you can easily answer the question. And then the similar questions like, how do you manage a patient coming with these sort of problems? So it's knowledge your diagnostic skill, knowledge about your management skills they will be asked. The pass rate is now, it's keep on increasing. It's around 70 to 80% people pass in the first attempt of PLAB 1. And this is into last 3 years ago, 76% passed in the first attempt. So the part 1, so once you pass part 1, you go into part 2, which is ASCII exam. For that, you need to come to England, which is an objective structured clinical examination. There are 20 stations and 11 stations. Now, after COVID, they're doing it more remotely. The stations are reduced, and they are expecting you to pass very few stations when compared to 11. And there may be some actors, there may be some communications and things like that. And again, they will be saying that you are a foundation doctor. You are told to see patient James, who has been referred by GP with pain in his big toe. How do you approach? And then you say, I'm taking history, examination, management, and so on. So again, you have need some sort of a training for that. Once you got the training, you should be able to do that. You always given a very clear information, and it was only 8 minutes. How it's assessed? It's a data gathering, how you are collecting your data before you are answering your questions, and your assessment skills will be assessed regularly. And how do you manage this patient clinically? With the evidence-based medicine, how you are going to come and show up. That's what you need to update about the National Health Service protocol and guidelines, which will help you. And also, how do you interpersonally your skills with the patient and patient families and relatives? How do you talk? These are things will be very much addressed on that one. Knowledge is tested in the first part. Your personality is tested in second part, if you think in terms of that. So simple scenarios like, I'm a rheumatologist, so that's why I'm talking about monoarthritis. So common disease are common. So always tell about the common problem is the common diagnosis. Don't give the rare syndromes where we used to give in our MD general medicine exams. So don't give the rare disease. The common things are common. And then rare syndromes, they won't be testing you here. The rare diagnosis is not at all expected in your things. So monoarthritis is a septic arthritis or gout. That's a common phenomenon. So you need to think about rather than talking about some metabolic bone diseases or etc. So you can think simple and you go very logically, you may be able to pass very quickly. Otherwise, it is very important you use your presence of mind. Examiners will be asking questions, what you tell to them, and they will take the questions from there. So you need to be inviting the examiner to ask questions rather than you are expecting him to ask questions. So read the instruction carefully in part 2 and keep up with your time is very important. Don't overrun. So for that, it will be practice. So don't worry if you mistake one session, just move on and you will be able to do it in another session very easily. And the pass exam in the PLAB 2 also very good recent years. And this again, depending on the available candidates and the comparison. Okay, how you prepare for that? Simple, concept-oriented medicine you need to understand, and it is qualification. You're already qualified, so you got the knowledge. You need to make some fine-tune. You will be able to get. These are the books. You don't need to read Harrison's or Surgery, Bailey and Love or anything like that. You just go and read these sort of Oxford handbooks of clinical medicine, specialty medicines, which will tell you a patient coming with coma, how do you approach? There are some clinical emergencies books are there, which you clearly, you might be following there in India, but you just refine and you must be able to easily pass this exam. So I conclude saying that to come to United Kingdom to pursue career is achievable. You can do it as well. And the other thing is you start preparing correctly at the right way, you can approach with a clear frame of mind, you could be able to do that. So this is my contact details, and I'm happy, I'm already joined the Telegram group, and this is my WhatsApp, and that's my email address. I'm happy to help if anybody want any advice. I'll stop here and thank you for your attention.
Thank you, Dr. Murthy. I think the judges, if they're ready, before starting the questionnaire for this session, I think our judges have been here with us for more than 2.5 hours. So let's complete the award paper presentation results. Prabha, can you stop sharing?
Balavaskar sir.
Dr. Balavaskar sir.
Good afternoon. Good afternoon.
Yes, sir.
We had to do some mathematics, so I had to interact with Dr. Divetia sir also to come to the conclusion. So on behalf of our team, I think we must congratulate all the participants. It has been a high quality presentation by all the speakers. Of course, they are students and there will be some sort of lacunae. So able to understand, and we definitely know they will do better. So out of the 8 participants, we had almost a common opinion about the toppers, 3 of them. The third prize, I'll talk in a reverse direction.
Sir, they are ready with the certificates in the 1, 2, 3 order.
Sir, 1, 2, 3 order, sir.
Okay. Please. The certificate will be displayed in that order.
I thank Dr. Divetia sir, who was also with me in today's program. The third prize goes to J. John K. SRM Medical College, Kanchipuram. He is there, I think. The second prize goes to Grishma R. Government Kanyakumari Medical College. And the first prize goes to Dr. J. Jellyfree, Government Teni Medical College. So congratulations to the winners and congratulations to all the panelists for having made a very useful presentations and very highly prepared and nicely prepared and attractive preparations for the day. Thank you very much.
Thank you, sir.
Okay, Divetia, sir, words from you.
No, thank you for making me part of this program. I think it's a very nice, great initiative to have a 3-day PG conclave. All the papers were very good, and some of the topics were in fact quite innovative, and even to grasp all these concepts in a short time of 8 minutes was hard. But I think congratulations to all those who took part, not just in the prize papers, but also maybe in all the other papers. So doing research or doing a study is always an education. No one is perfect, and nothing is the absolute truth. And I think the science is the quest for truth or quest for knowledge or whatever it may be. And I'm so happy to see so many papers and so many high quality papers coming up. So congratulations to all the students, their guides, and of course to the organizers, Dr. Sudarshan, Dr. Kumar, for actually organizing, and Dr. Edward Johnson for organizing this very innovative conclave for PG students. And I was very happy to be a judge for this, and thank Dr. Balabhaskar. We had also some good discussion on the topics. So thank you very much, and congratulations to the winners, and also congratulations to all those who did not get a prize, but they did very well. And I think they should be proud of themselves, and the guide should be proud of them as well.
Thank you very much, both the judges. It was wonderful to have you both. I think it's very difficult to get both together at the same time. I think none of the branches throughout the country, they were able to manage both the stalwarts at one place online to judge award paper. I think we are very fortunate. I think students are more fortunate to have your advice and sort of take a lot of clues from you how to sort of present in big conferences and how to go about in research work. Thank you so much for your kind presentation. I think over to Edward, we'll go ahead with the next talk.
Thank you.
The other certificates also.
Thank you, Balabhaskar, sir.
Yeah.
Thank you, sir. Thank you, sir.
Congratulations, award winners. It's a great chance. You are selected by two past IJA chief editor means you can assure that your paper presentation are presented in the international journals. So you're like that. So because it is selected by the two renowned persons of past editors of IJA. Thank you so much, sir. So we will move on to the next
Can we display the other 3 certificates again?
Display. We'll go ahead.
Okay, we will move on to the second speaker, Satya Francis. I invite Satya Francis, please. Satya Francis, sorry. Okay, thank you.
Sorry, I'm just taking a minute to upload the thing. 1 second.
Stop share. Try again.
Yeah, you're there. Just need to go on slideshow.
1 second.
Technical team is there.
This is a Mac. I just need
Mac,
to.
They
That's
can
why
guide
I'm
from here.
probably struggling with.
Go to the slideshow, James.
Next one. Yes.
Correct.
Click that. Click that.
Click that, James. Yeah. Yeah, that's
that'll be fine.
No, but I want the presenter view.
No, this is fine.
Presenter, yeah. This is the presenter view, and you will be seen by the side of that, and you just need to advance the slides. We'll hear you. You will be there.
Yeah.
Oh, you're not getting your.
Yeah, my presenter view.
Right. In which case you need to go to the settings or Control F5 or something. You need to press. Try that. Control F5 or F7, so one of the two.
No, I can't.
The movement arrow is on the bottom, Satya. Yeah.
Sorry, I just.
Do you want Krishnan to do the other talk and then you come back?
Yeah, I think Krishnan, you can do it, and then I'll get into it if he's ready.
Sir, unmute yourself, sir. Unmute.
Yeah. Krishnan, do you want to carry on, and then I'll try and.
You need to unmute, Krishnan.
Okay.
Yeah. Are you able to hear me?
Yeah. Yes.
I'm Satya. I'm very happy to go ahead if you want. Please. Okay. That's fine. Share screen. Be able to.
Yeah.
Well, I don't know why he's gone to the second stage. Previously.
Go back. Yeah.
Right.
You can.
Good afternoon to everyone, and thank you for the organizers, and thank you for the Professor Murthy who asked me to give a talk about how to be successful anesthetists in UK. As like Professor Murthy is advised, when we came to this country, we didn't have enough guidelines or anything, no support or anything. We didn't know the informations how to succeed in this country. After a few long struggles, we are able to get into the system, and then we are able to get into the consultant post, and then we are trying to help the juniors to get into the successful. I never ever regretted the training in the UK because I was trained from Madurai, Madras, and Middle East, and then I came to this country. I never ever regret that I have came to this wrong country or anything. I always welcome this country. As Professor Murthy told me that the country is very safe and is very safest country in the world. When you want to come to work in this country, there are 4 steps I need to talk about. The main thing is GMC. What is your aim of to come to this country? What kind of jobs you can take? And then I'm going to talk about visa, what kind of visas you need to go into the particular post or anything. From October 2019, there is no more priority for the local candidates. In the past, it was for local candidate first priority, then Europeans, and then the non-Europeans. From 2006, it was struggling for a quite long time. The current government, conservative government, changed their ideas and other things. There is no age limit. This is what I'm trying to say, because some people in India and other places where you got an age limit to work in this country. In the UK, you can work at any time. You can work up to the age of 74 or 75, even somebody's working more than 75. My colleagues are working at the moment are 72, 69, and all these things. So no need to worry about your age. You can come to this country at any time, at any time. Okay. GMC registration. This is more important. Anybody who want to practice in this country, you need to get a GMC registration. As Murthy has already told you, you need to open an account and then prove yourself you got a good English. As I said, IELTS or occupational English test or both are equivalent. But if you want to work practice in this country, this occupational English is enough. In the past, it was only IELTS. IELTS is a little bit harder because the 4 component is more of academic more than medical. Your medical degree should be recognized by WHO. So please check with the GMC website and then make sure that one. In the past, even our Chengalpet Medical College was not recognized in the past. Nowadays, it's recognized, but most of the Indian private medical colleges are not recognized. Make sure that your undergraduate and post-graduations are verified by electronic portfolio verification system. There is a website is there. You enter your degrees, they will verify your degrees, and then they will say that yes, you are eligible to apply. Murthy has explained very well how to approach for a PLAB exam. For your PLAB exams, you don't need to be a foundation. You don't need to complete your house officer job. You can, after finishing your final exams, you can give a PLAB exams. You can give Royal College of Fellowship exams, whether anesthesia or surgery or any medicine or anything. You can get a GMC registration. I will go elaborate a little bit more later on, and then you can get a GMC registration with overseas qualifications or MTI program. For all GMC registration, you need a good standing certificate from your medical council.
Sir, your volume is a bit low. Can you just, your audio is a little bit low. Can you just increase your audio in your computer?
Yeah, I don't know. Can't see the audio settings.
No, it's all right, I think.
Yeah, okay.
Yeah. It's reasonably okay.
Right. Sorry about that. Okay. Murthy is already explained very well about how to approach for PLAB exams. It is only an internship, found a house officer level, clinical level, which is not a difficult one. Regarding time management, he's already spoke to you. The PLAB 1 is got a 3 hours test, the MCQs, each 180 stems. So you need to finish one stem within 1 minute. PLAB 2 is 18 stations. So each station has got 8 minutes to complete the work. It is most useful way to come to this country. The reason is very easy, less expensive. For each PLAB 1 and PLAB 2, just 6 weeks of preparation is enough. I'm talking about 6 weeks means 6 weeks really in depth to prepare. Okay. Please, if you want to come to this country, please do it sooner than later. The problem is in 2024, UK medical licensing assessment exam is coming. Even local UK medical graduates has to do these exams. If it comes to that one, it is going to be a little bit difficult because the percentile is it's more of percentile than a percentage. It is like a US assembly. So please, if you want to come to the country, come to this sooner than later. Right, I'm going to talk about what is fellowship exams, especially the Royal College of Anesthetists, because this is mainly is involved with the Royal College of Anesthetists. If you pass primary exam, you can give it from your home country. You can get a registration with GMC. Okay, the GMC can accept this primary. Only Royal College of Anesthesia only is allowed for primary FRC to register with the GMC. Whereas in other fellows, like a surgery or medicine, you need to complete your full fellowship. The reason is because after finishing your primary FRCA, you need to come to this country for your final FRCA. Okay, that's all you can do that way. Your post-graduation, yes, you can complete your training and then you can come to the registration. For that, I will establish a little bit later on. For your fellowship Royal College of Examination, you can get a temporary examination eligibility with the college. That means the college has to approve you for your exams. Primary, I think so Satya will elaborate this topic more than me or anything. Right, I'm going to talk about more of regarding how to get a system into GMC registration, sponsorship program, or otherwise called MTI program, medical initiative training program. This slide is so big, more crowded, but I need to emphasize more a few things. That's why the slide is a little bit more crowded. It is aimed for the lower middle income countries. This post is you should be a post. You need to be in that country for 12 months. No point in coming to this country and then apply for MTA. You should have minimum 3 years experience in the concerned specialty, and then you have to prove yourself post-graduation evidence. I'm talking about a master's or diploma. For the Royal College of Anesthetists, depend is more valid than the degrees. The reason being, depend is most standard exams, whereas the MD exam is a little bit variation between the different to the individual colleges. All right. It is useful for Education Commission approval by the foreign medical graduates. It is not useful for British people or European citizens. What I mean, some people who are British citizens, they will go into India or other part of the world. They will get a degree, but they will try to come to the MTA instead of going to the plan exams. Even if you are a citizen of this country, if you go outside the UK, if you get an education, you need to give the plan exams. No other way. Okay. But if you are coming through the MTA, there's no need for the PLAB exams. This post is valid for only 24 months. You can, after 24 months, you need to go back to the country, or it's up to you. With this one, you will get a tier 5 visa. What is mean tier 5 visa means? You will get it 5 years and 2 years visa. You can come with your family or anything, but after the end of this one, you should go back home. What is the advantage of MTI? Yes, you will be given like a training, like a national curriculum. You will be given all the trainings, whatever is structured in the college. So it's a good opportunity for you to get the training within 2 years. You will be allowed to sit for exams, for your fellowship exams. The advantage of the college is gives you 12 months free membership. Before applying for MTA, you need to go to the college website and give a consent, that is checklist. The checklist is just what is your name, what is your qualifications, have you sit before PLAB, what is your intention, that kind of things. Please, you do that one, then only the college will sponsor the letter to the General Medical Council, and then the General Medical Council will give you license to practice. For this step, you need to get a job before getting into the college to sponsor. Without a job, sponsoring for the college will be very difficult. Right? You can get a GMC registration with the fellowship programs. You can stand alone for fellowship programs are happening in different NHS. You can apply for that one. They can sponsor it. I forgot to tell you, any GMC registration you need, without English, you cannot come to this country. So fellowship, you can get so many fellowship programs for 12 months. You can get it from the Anesthesia Fellowship Organization, Regional Anesthesia UK, or individual hospitals. They got the fellowship programs. It varies from anesthesia to different specialties. It depends upon the need of the specialties. They will change it for fellowship programs. This is minimum for 12 months, and then you can apply from India, and then you can get this one. But for that, most of the times you need to get a good reference from your home country, and then they should refer to you to the fellowship. Right? Some people ask overseas qualifications. What I mean overseas qualifications, people who studied in India, they migrated to different part of the world, and then they get the post-graduation in different part of the world. Right? I have seen the people, even for undergraduates, they went into study the medical in Ireland. Some people, they went to Australia. Some people regarding Pakistan and others. I have seen one of my college junior, he went to, after finishing medical school, he went to South Africa and has completed a post-graduation in studies in South Africa, and then he came to this country, and then he moved to Canada. So the people can do that case. The good things about I'm really very sorry to say, because if you compete in Pakistan, Sri Lanka, and West Indies, all this, they are recognized for primary, equivalent to the primary FRCA. Whereas if you do complete a medical MD anesthesia in India, it is not recognized for fellowship or anything. European diplomas. Two types of diplomas are available. One is from the anesthesia, one is anesthesia in intensive care unit. If you complete that one, you are eligible to register with the GMC. You are exempted from the primary FRC as well. Right? Why do you want to come to this country? Murthy is asked so many questions, but if you want to come to this country, what is your aim? The aim is whether you want to be a consultant or do you want a non-consultant post. If you want a consultant post, whether you want a substantive post or locum post. To get a substantive post, there are three pathways: CCT, CSER, combined program, or CSER alone. I will give a little bit details now. I will not go in the deep, but you need to know how to get the job or where you get the training, where you want to become a consultant. Right? CCT pathway, UK medical graduate. After finishing the medical graduation, you can go do 2 years foundation house officer job. Then you can apply for the completion of certificate. Then you can apply for core training for 2 years or ACS training for 3 years. In this ACS, you will do anesthesia as well as A&E and other medicals. After completion of training in the core, you need to complete your primary FRC board. When you got that one, then you can apply for specialty training post. There is another selection process. After that, you will get an intermediate level training for 2 years, and then you need to complete your final FRC. Then you progress to advanced level training for ST5 to ST7. After completion of 7 years, you will be awarded CCT in anesthesia. Then you can get into consultant anesthetist post. In this one, if you are interested in a subspecialty, you can do dual accreditation with the intensive care medicine or any other specialties. Right? If you don't have that facilities, you can get into, because most of the international student medical graduates like us go with the house officer 12 months internship. Then you have already had experience in anesthesia. It should be minimum 18 months of anesthesia, 6 months non-anesthetic training, like an intensive care unit, or sometimes in medicine or any other specialty. And then you have to prove that you got a you can apply for specialty training post. I will go into the selection process a little bit later.
There is a problem in audio.
Audio con, I think.
Nothing has a connectivity problem. We'll wait for a few minutes.
Yeah, okay.
Yeah, I hope it will be all right.
Please unmute yourself.
Please unmute, sir. Dr. Krishnan, sir.
Yeah, I have it, but it's not going to the next slide. I don't know why. Okay. Yes, I was talking about the CSER combined program. From your CT1 and CT2, when you go for a specialty training, there is 7 dominants in the self-assessment criteria. It is scoring system. You need to score from 0 to 4. Each dominant is got domain got 4 points. There are 11 domains, so it each you are scoring. You can assess yourself how much you are scoring, and then you know whether you are eligible for specialty training or not. For example, undergraduate training, undergraduate degree, usually everybody will get MBBS, but in this country you can have additional degree like a BSc or something. When you got a prize or something, the scoring will be different. Apart from anesthesia, if you have done intensive care medicine or something other specialty, you will get more. I will not specify everything, but most of the times you will kind of difficulties. We are scoring from India. People will not score in the clinical governance, audit, and quality improvement programs, because this is not well taught in the back home. So you need to concentrate how to score in these areas, like research, PhD, and teaching. This all you need to know, prove yourself, and getting scoring more. And academic publications. What I'm talking about are publications, you need to be a first author. Second author is value less scoring, but if it's a first author, you will get 4 marks. And presenting papers and all these things. And then prove yourself that you got a up-to-date ALS, ATLS, and then outside medicine, like a leadership quality and all these things. If you have done any social activities or running programs or other community activities, this all give you a scoring, then you will be eligible for specialty training, year 4 or 5 and other things. For specialty training or anything, you need to score the current, you should score more than 40. If you are scoring less than 40 or anything, the chance of getting the specialty training post is very unlikely. Right? So after the CISA program, a combined program, you can complete 5 years training.
Krishnan, there is a problem in your audio.
No, it's a connectivity internet problem. Very rare to see in UK. I don't know why.
Sorry.
Yeah, maybe.
Are you able to hear?
Yeah. Better.
Okay. Now GMC is awarding CCT if you have more than 3 years training. If it is less than 3 years, it will give a CISA program certificates.
Your slides are not seen.
What?
PowerPoint is not seen.
I don't know what to do.
Share the screen.
I'm able to see it. I don't know what's happened.
You can close it and reshare, sir. No problem. Stop share and then reshare.
I'm going to stop and store, right?
Bandwidth is very low, so that's the probable reason why.
Sorry?
Bandwidth for your internet might be low. I think it's improving now. I can see that. So you can try to share it.
Are you able to see the slides?
No.
No. 1 second.
Hello, sir. Initially minimize the zoom, sir. Then open the folder. Then select your PPT. Then maximize the zoom and share screen, sir, from there.
Sorry, what did you say? I minimized.
Yeah, sir. First minimize the zoom, sir. Then go to the folder. Then open your PPT. Then again maximize the zoom and select share screen. From there you can share your PPT.
Slow down. I'm not quick enough for you.
Yes.
I was giving the lecture and all of a sudden it's gone down. No. Are you able to see it?
No.
No, sir.
Krishna, minimize your zoom first. Yeah, now.
Yeah, sir. Now you're sharing.
Yeah.
Proceed, sir. Yes.
Go to presentation mode. Yeah, now
Yes.
you can see. Yeah, see.
Are you able to see?
Yeah.
Yes.
Okay.
It's visible.
Right. If you sorry, I'm really very sorry for that one. If somebody doesn't want to go to the training pathway, if you are already experienced in anesthesia, you don't want to go to any other training in this UK, then you can use the TNISA pathway. It's called Article 14. What is mean by that? After your medical graduation, 12 months internship, you have to provide so many paperwork, your experience, what you are in each specialty, and then submit to the college. And then you will, if the college is approved, then you can get CSER program. I will go into the little bit detail in that one, right? Article 14, some of the people who has already experienced, if you are a little bit old age, you don't want to get start from the training, then you can submit your paperwork from India and then come to the college. The college will approve. In the college, two evaluator review the application form. Regarding the evidences, what I'm trying to say, the evidence is very, very difficult. You need to each and every cases, you need to prove yourself. It was signed by the supervisor, and then it is should be attested by the notary, and then you submit to the college. The college will review that one. Two people review your application form, all the paperwork, and then they submit to the college secretary, Royal College of Secretary. They will recommend to the General Medical Council. The General Medical Council will review your paperwork and ask some other questions and other things. If they are happy, then they will give you a CSER program, your registration, specialist registration, then you can practice in this country. But if they found any training is missing or anything, college will not offer your training. Then you need to do your training yourself. You need to approach the different NHS and then get your training. The problem is with the CSER degree, you cannot, some of the countries, they don't accept the CSER as a valid consultant. So before you apply for this process, please check with the country where you want to go. Like in India and Middle East, CSER is not recognized. But in this country, it's accepted. You can become a consultant and work as a consultant in this country. Right? If you don't want to progress your life as a consultant, then you can become a non-consultant carrier, like a trust grade or specialty doctor. Trust grade is a SHO level, a specialty doctor level is registrar level. You can stay in that post for quite a long time. You can start, and then you can retire as a specialty doctor. Sometimes you can apply into a locum consultant post. For that locum consultant post, you don't need to be in the specialist register. The problem with the locum consultant post, you cannot do private practice, you cannot supervise the juniors, you cannot give a reference or anything, but you can come and do your job as a consultant level. The problem is some of the times locum consultant post is good for you towards the end of your career, where your basic pay will be increased, so you get a good pension. People who have done so many times, like a locum consultant from trust grade to locum consultant. As I said, non-consultant career is a good pay. Sometimes my specialty doctors' pay is more than my take-home pay. I'm not talking about they work hard, but that's what I'm trying to say. With the less responsibility, the work-life balance is too good for the non-consultant carriers with less responsibilities. How to get a job? As I said in the past, you can get first GMC registration and then you can look in for your jobs from the NHS website or specific fellowship post in the different NHS trust, and then BJA will advertise all the jobs or anything. If you are not sure, you contact your other colleagues or anything, or your seniors or anything. Like Professor Murthy and myself, we can help you in getting some of the jobs. Right? I was talking about visa, what kind of visa is needed or anything. For work permit visa, Tier 2 visa is needed. If you are coming from Tier 5 visa, it's not going to be useful. The reason is because Tier 2 visa is you can bring your spouse, but you cannot bring your parents, but you can bring your parents for 6 months. After 5 years of Tier 2 visa, you are eligible to live in the country indefinitely leave to remain. After completion of 1 year of ILR, you can get a citizenship. It's up to you whether you want to go. I will recommend whoever is in the Tier 2 visa, go to ILR. Because otherwise, if you are in the Tier 2 visa, you need to always spend more money to get the visa, thing. Right? The good thing about the fellowship degree and CCT is always recognized all over the world. You can't go to Australia. You don't need to give you any club or any kind of similar entry exams. You will be recognized to work there. You can be welcome to consultant level. As is Murthy told, for getting into Australia, English test is important. Occupational English test is enough, but IELTS is not necessary. You can get a job in Middle East, no problem at all. If you want to go to America from here after getting your fellowship and CCT, yes, America, they allow you to go to recognize this degree. You can get a fellowship or you can work in the university hospitals. But if you want to different private hospitals or anything, you need to give the USMLE. You can go to Canada. These degrees are recognized. CCT is recognized. You can go and work as a consultant, though you don't need to USMLE kind of exams. So I will be very thankful to my whoever is helping in my life. There are so many people who are helping in my life. I need to take an opportunity. I need to thank you to Dr. Ramamurthy, who is at the moment is working the professor in the Stanford University, California, and Varadarajan, who is helping me all the time in the social activities and other things, and retired Professor Balakrishna and Rajendran, and my anesthetic department colleagues from the Madras Medical College. I'm really very sorry I didn't put my email or WhatsApp number or anything. If you have any queries, please feel free to contact me at any time. We will be here to help you, like Murthy, what he said. Thank you very much. If you have any queries, please feel free to call us.
Thank you, Krishnan sir. We will move on to the next speaker. Satya ma'am, are you ready? Satya madam. So most of the questions in the chat box are answered by the Armugham, Dr. Professor Armugham. So we will move on to the next section. Dr. Satya madam, are you there?
Yeah, I'm trying to get the presentation up. Yeah.
Okay. Please go.
You can see your both.
How is it?
Yes, it's visible through screen.
What?
Share.
See the presentation. Switch to share.
Your screen sharing, James.
Can you guys see us?
Oh yeah, I can see. Yeah.
Can you see now?
Yeah. Proceed, Satya. On the left-hand side, you have this button you can easily change. Yeah.
Yeah.
Go ahead, Satya.
Yeah. Thanks to the ISA organizers and Professor Murthy for the invite. It's a pleasure to share my knowledge with regards to the FRCA examination. I've been an examiner for last 7 years, and I'm also lead for the clinical SOE part of the final FRCA examination. I have no disclosures. So we will start with a primary, as you're all eligible to do this exam without having worked in UK. The primary FRCA can be a daunting task, like any other overseas exam. The syllabus is broad, deep, and requires a high level of understanding rather than just knowledge. So the purpose of this talk is to outline a strategy for preparation and success. My aim is to give you an overview of the exam, suggestions as to how to approach both the preparation and the viva itself. Apart from the standard books and guides available on the market, I'll also mention some of the very useful resources which you can access very easily. And finally, some tips, do's and don'ts for your written and oral examination, and also how you could achieve this in your daily practice or learning. because that's how our trainees do. As an anesthetic trainee, you can apply for primary FRCA from India or anywhere overseas after 6 months of training. But generally, we advise our trainees to take the written examination after 6 to 12 months. How would you get the temporary examination eligibility? All the information for this is available on the college website. What you require is the recognition with the medical council, a proof of primary medical qualification, and proof of foundation training, and that which is equivalent to your internship, and proof of specialty training in anesthesia of minimum 6 months. This can be a certificate or a letter from your organization or institution. You have to pay a fee for getting a membership, and the annual membership for T is £100. The next session to apply opens in April 2021 and closes in June 2021 for you to sit for the exam in September. Luckily, the written exam is happening on a virtual platform, and this is likely to continue in the future. First of all, it's worth remembering the exam is really matched to the syllabus. Therefore, the first thing I would recommend doing is downloading a copy of the syllabus. It's a core level training for primary and intermediate level for final FRCA. So there's no cutting corners. Without proper preparation, you cannot succeed this examination. So the primary written examination has only one component, which is MCQs. It is a 3-hour examination with 90 MCQs. It has equal multiple true or false or a single best answers. The single best answers are more weightage. As you can see, I've subdivided them into various sections. This holds true for both multiple true or false and single best answers. All this information is available on the college website again. The bottom line is that you make sure you read all the key topics, answer lots of MCQs, and keep on doing these closer to the exams. And the questions are frequently repeated, and the past MCQ papers are very relevant in your practice. The more you practice, the better you get it. What are the common mistakes that candidates do? Attempting the exam without adequate preparation, or relying only on the past medical question papers and memorizing the questions. And also, one of the recent exams, the multiple true or false were performed very poorly. Possibly this is due to increased number of new questions. So the top tips for good performance will be knowledge. So textbook reading is very important. And the next step is doing the MCQ papers in real time. That will help you find your deficiencies or weaknesses when it comes to the exams. Is it lack of knowledge? Is it time management? Or is it your technique, not able to read and understand the question well? So I think it is important. This is why you have to practice it in real time. Coming to single best answers, I definitely would recommend the clinical experience is very helpful, and it helps a lot, and it will often come to your rescue. So one other suggestion I would say to my trainees, and I think it will hold good for you, is to work in a small groups. Make your own single best answers and give options, and you discuss that with your friends. And so this will reflect your preparation and how you could go forward. And it is a very good technique to practice well. So once you have passed the MCQs, you will be asked to come for your oral examination. Since pandemic, we are doing this on virtual platform that this is going to continue till June, but this is normally a face-to-face examination and you'll have to come to UK for this. So moving on to the second part of the primary FRCA, it consists of OSCE and oral examination. So you're already familiar with OSCE examinations, as this is happening now in undergraduate training and postgraduate training in India. So the top tips I would say is to watch the primary FRCA examination website. There are plenty of run-through videos, which is accessible on YouTube channel. So first thing I would say is go on, look at the sample videos, and that will give you an idea what you should be doing at every station. So this is an example, it is held in a room and divided by many little cubicles. There are 16 active stations and each station is 5 minutes long with a 1 minute break in between to gather your thoughts and read the instructions for the next station. And I just wanted to show you a simple representation of the stations on OSCE. There are two things I would stress here is the interactive resuscitation skills and emergency clinical scenarios on SIMMAP. You must be up to date with ALS guidelines. And also there is a quick reference handbook on AAGBI website. It's a very useful tool. It gives you a very structured approach and troubleshooting suggestions for all your anesthetic emergencies. This is what you will have it on a simulation scenario. So a brief word about how they are scored. Each OSCE station will have 20 marks and the pass mark for each OSCE is different. And the pass mark for the whole OSCE is the sum of all the pass marks for all 16 stations. Usually it ranges between 225 to 240. So the top tips for OSCEs are ensure you follow a numerical order. So you normally go around clockwise. And the critical 1 minute is important to read the instruction, what you're getting into. At your level, at the primary FRCA level, rarely anything complicated. And do not be affected by your bad performance. Take a deep breath and clear your head for your next station. Moving on to the oral examination, structured oral examination. It has two parts. One you'll have in the morning and one you will have in the afternoon. It is designed to test your understanding. Clearly, candidates will require a sound knowledge of the curriculum, but questions are constructed to allow the examiners to probe deeper into this knowledge, to assess the candidate's understanding of scientific principles and their application to clinical practice. For example, you all know how to do an alveolar gas equation, but could you please apply that in high altitude? And you should be able to substitute the values and say how that affect the signs and symptoms. So it's applying your knowledge to the clinical scenarios. So there will be two examiners marking independently and no agreed marks, and the scores from SOE 1 and SOE 2 will be combined for a pass or fail mark. Currently, the pass mark is set out at 37 out of 48. So now we are moving to the final FRCA exams. As you all know, you must have worked in NHS for at least 1 year to become eligible for the final FRCA examinations. And therefore, T applicants are not eligible unless you take up a role in the NHS. So moving on to written exam in this part of the examination, it has two components. So you have an MCQ paper like before, as in primary, and the second one is the CRQs. As I've already outlined what you would have in your MCQs, it's again multiple true or false and single best answers. And here you will have your subspecialty units and optional units. Again, you'll have to go through your curriculum, and it is the intermediate level of training, and download the syllabus and match your preparation according to the curriculum. The constructed response questions is a replacement of your past short answer questions. It's a new format, again for 3 hours, and you'll have 12 questions, and you can have multiple sample questions in the FRCA guide. And one STEM will have many subsections so that it will be more easy to answer and less ambiguity to correct. And it is very easy for us to do this practically. And it is the way forward, and it has happened in the last 2 years. Once you cleared your written examination, you will be called to do your oral examination. It consists of 3 vivas. So you would have come across 3 pairs of examiners, totally 6 examiners. And the scenarios will be linking to clinical science in the morning, along with your clinical scenarios. And in the afternoon, it will be purely a long clinical case and 2 short clinical cases. Again, you can watch sample videos on the college website. It is all done by the examiners. So it is the important thing, people practice and look at these videos so that they understand how the oral examination goes on. As you are already aware, there are multiple and plenty of books, standard books, and guides for primary FRCA and final FRCA available. But there are certain things I would like to recommend is the FRCA guide from the college. Of course, you have to pay a fee for it, but it is worth having it. And college recommends e-learning anesthesia. It is free for our trainees in UK, but you have to pay a fee for it. And once you become a member of T, they do have a 25% discount on this. And another useful website is Anesthesia UK. You have tutorials and all the topics being discussed and all your past papers. And of course, college YouTube channel. And AAGBI website will have this quick reference handbook and all other guidelines and the reports and nice guidelines too. And also BJA has articles on your continuing education, and that is very relevant to exam topics. So for example, I'm going to give you some tips how to approach the oral examination. It is an opportunity to show what you know. And it is a discussion. Just think you are presenting to your consultant at work a situation or clinical scenario, and there is rarely one correct answer for any of these. There is no college or an exam answer. Say what you would do, and if it seems to be getting difficult, it is actually a good sign you're doing good. Few more top tips for your preparation. Know your stuff, no sympathy vote. Speak clearly, slowly, and loudly. Think before you speak. Never argue with the examiners. Know your graphs, diagrams, and equations. We very, give importance to how you can explain things of drawing, with the diagrams or your equations. When it comes to clinical, it's a structured approach, ABC approach. Call for help early. Imagine you are at work and how you would proceed normally. They want to know you're safe, not an expert in the examination. So there's no substitute for knowledge and practice. I would nag your consultants or senior registrars per practice. And good luck. This is a hard exam, and if you pass, give yourself a pat on the back. Thank you.
Thank you, madam. You have given a very valuable tips how to prepare ourselves and face the exam. So one of the interesting tip you have given is the work out the answers before you look at the option. It's a great tip, madam. Thank you. I would like to thank Professor Murthy, Professor Krishnan, and thank Professor Murthy. He answered most of the questions in the chat box. I hope Bina Astana, most of your questions are answered. So we come to the end of this session. Hand over the session to Dr. Kribara.
Thank you, Dr. Edward. It was a very informative session. We thank all the three speakers. It is definitely useful to all the postgraduate students. Thank you so much on behalf of Tamil Nadu ISA. Now, I want to make one announcement here. All your certificates can be downloaded after submitting your feedback form in www.isatn.a1logics.live. Okay, so please note down the website number. Then our next week program is sponsored, will be hosted by ISA Trichy branch. So we'll be having a regular webinar on the next week at 11 o'clock. So with that small note, we will move on to vote of thanks by our treasurer, Dr. Ratna Kumar. Dr. Ratna Kumar, please.
He's around?
Yeah, I think he was here.
Was there? There, sir.
Okay.
Ratna Kumar, unmute பண்ணுங்க.
Tell him to unmute.
Unmute. Unmute.
Ratna Kumar, please unmute and proceed.
Unmute பண்ணுங்க Ratna Kumar.
நம்மளே பண்ணலாமே.
பண்ண முடியல.
Rakshita, can you do that?
Rakshita.
Allow him to unmute.
Hello, sir. 1 minute.
Ratna Kumar Chellaswamy.
1 minute, sir.
Maybe it is not allowing.
Make him co-host.
Yeah, Ratna Kumar. Yes,
okay,
correct. Okay, fine.
Yeah, Ratna Kumar, please.
Okay, okay, sir. Thank you, sir. First of all, I would like to, as a member of ISA Tamil Nadu, I would like to thank our President, Dr. Sudarshan Kasturi, Secretary, Dr. Prabharan, our President-elect, Dr. S. Kumar, and our Academic Coordinator, Dr. H. Johnson, for laying the foundation stone for this Tamil Nadu ISA PG Conclave. Thank you, sirs. Thank you for your tremendous efforts for quite a long time. It has been a very informative thing for us, and I also learned many things from the presentations. I thank you, sirs, first, and then I thank Dr. Ganesh Prabhu and Dr. Bala Venkatesubramanian for their advices. I thank Dr. Edward Johnson and Dr. S. Kumar for steering the scientific committee, and Dr. R. Selva Kumar, Dr. C. Ganesan, and Dr. R. Ganesan for their significant contributions. And they thank the whole committee constituting Dr. Siva Prasad, Dr. Sandil Kumar, Dr. Radhika, Dr. Ramya, Dr. Amar Nanda Kumar, Dr. Manigandan, Dr. Arun Kumar, Dr. G. Balaji, Dr. Malini, Dr. Balasubramanian Ganesan, Dr. Akila Sen, Dr. Sandil Kumar Mohan, Dr. Yoga Satya, and Dr. Gunalan for their tremendous contribution towards this scientific sessions. And I thank all the coordinators coordinating on both days, Dr. Selva Kumar, Dr. Ganesan, Dr. Amar Nanda Kumar, Dr. V. Balasubramania, Gunalan, Dr. Akhila, and all the judges for day 1 and day 2. And I thank all the delegates as well as the postgraduates for their significant contributions towards this Tamil Nadu ISA PG conclave. I thank you. And I thank our President of ISA National, Dr. Muralidhar Joshi, and our Secretary, ISA National, Dr. Naveen Malhotra, for their felicitations in the morning. I thank the award paper session judges, Dr. Balas Bhaskar and Dr. J.V. Divatya, for judging today's session, and the career guidances provided by Dr. Murthy, Dr. Satya Francis, and Dr. Krishnan about our pursuing our education as well as practice in UK. And my special thanks to the ISA Coimbatore, Madurai, Salem, Tirunelveli, Tanjavur, and Chennai for their contribution towards the awards. And finally, I thank A1 Logics for providing an excellent electronic platform. Thank you. Thank you, one and all.
Thank you, Dr.
Thank you. I think major beneficiaries should be the A1 Logics. I think
A1 Logics, they did a fantastic job.
Praveen, Shilpa, Rakshita, and the entire team, they did a wonderful job for all the 3 days. I think a big kudos and claps to them. There's nothing, no words to express our. I think we have done in the past more than a dozen conferences to my knowledge. But all those conferences, we used to do all the hard work. But this time, everything was done by A1.
And we are coming and sitting.
Yeah. Yes, correct. I think thanks to them, I think the virtual platform has made things much simpler for the organizers. But eventually, everything went on very well. I'm so glad and happy to do that. And I think, as Kriba mentioned, next week we will have the weekend webinar continuing on 11 o'clock. At 11 o'clock, and for the New Year session, we'll have last of the series of webinars from Coimbatore. That will be on the first Sunday of January next year. Till then, I think very big goodbye. Thank you to all the speakers who joined very early in the morning from UK, and thank you so much. Any other words anybody wants to share?
You.
Welcome, and thank you so much.
We can end the meeting.
Conclude the session.
Yeah.
That's Satya and everybody. Thank you so much. Bye.
Thank you, sir. Thank you, Thank you, Professor. Excellent work. Thank you.
Thank you.
You can adjourn the meeting now.
Good.
Thank you. Bye.
Thank
Yes,
you.
thank
Bye-bye.
you. Meeting closed. Rakshita, you can close the meeting. Thank you.
Thank you. Thank you, A1 Logics team. Thank you so much.
Thank you, sir. Yes.